out what you need to study in terms of how to tell the difference between some of the disorders. And I think the slides, focus on the slides because they do have, when you talk about oppositional disorder or autism, different things, remember she did a pretty good job. I reviewed the slides on saying what's the same and then what differs. Okay, right? So taking notes that way, try to keep the signs and symptoms straight. Do you have anything to add on that, Dr. Beecham?
No, I think that's a good message for studying is to really use those PowerPoints as your outline. And what I've told some folks to do is actually blank out what's on the PowerPoint once you've done some studying and see what you actually know about each topic item. Like how much can you just fill in? And that kind of highlights what you really know and what you might need to go back and study.
Yeah.
So I'd really use those PowerPoints as kind of my guideline.
Right. And so for those of you that aren't coming in for those half-an-hour meetings, that's the type of stuff that we're talking about. So I want to make sure everybody's getting that, where you feel like you're getting all that info. Most of the time, the first couple minutes, we talk about how people are studying, how they prepared in the past. And you guys have been great, very, very honest too, which I appreciate that. Like, this is what I've been doing, here are my notes, this is what and so Dr. Beecham and I can work with you on how to go forward on that and change that up a little bit. So most people figure out this year, in their junior year, that what was working for them in their freshman and sophomore year might not be working as well, okay? And so that's what we're here for, to sort of help with that, given that we've done this for many years and taken multiple tests and lots of schooling. It does ramp up a little bit this year, as you've probably seen in adults. All right, any questions that any of you have for us? Those of you that have come in to meet with us, anything you guys can add is in getting some of your colleagues to maybe do the same. People have met with us and sharing any of that. Okay.
We have somebody here speaking.
Okay.
Pull out from all the guest speakers, you know. I mean, we used to with you guys, your content, but when we have a slew of guest speakers, then we can't. I know I do. I get I don't know what to really put out. What you want us to get from those guys.
Okay.
And again, I would concentrate on slide set, and if there was those PowerPoints, and then if there was anything that we felt might be in addition to that, we might circle back around on it.
Yes, and remember that the objectives that we put in present, that's what we're so again, it's the big picture is lots of reading, skimming that, making sure you go through all of that. But when you come to class, that's why I want you to read, so that your brain can hear what I'm saying and not feel so overwhelmed by the topics that are being discussed. That's why we read before we come. Because if you don't, then you feel stressed. You're like, oh my gosh, there's so much that they're going over. And your brain just shuts down. Okay? So if you read first, you're not going to have that experience. You're going to be like, oh, I've heard that term, or I'm going to, or write a little note, like I need to read about this a little bit more. But then the PowerPoints, so all of the PowerPoints that come into us from guest lecturers, they're really the experts in the field. So there's some top-notch people that are coming in to do this work. We're looking at those PowerPoints and we're making sure that they're covering what we need to as for our competencies within the course, within the School of Nursing, so you guys get what you need to get. Okay? So that's why we say, yeah, it's kind of like an outline. The PowerPoints are the outline. When I get questions like, can you give me the outline? I'm going to say the PowerPoints are the outline. Okay? And then going from there. All right. All right. Any other questions? The hard thing was that you had the test, and then you had grief and loss, and then you had more about child maltreatment. So some tough weeks and the test. So your brain was probably a little overloaded as well. So it's harder to hone in on what you need. But don't give up. A lot of the stuff that's coming forward is going to be some pretty interesting stuff you're going to have more, especially if this is something that you want to go into. It's going to keep honing in on.
And it's pediatrics. Come on, it'll be great.
I'm going to say, right? Many of you have already raised your hand that this is what you're going to.
Now we got the fun stuff going on.
Well, hey, come on.
And we've all experienced,
labor and birth, right?
we have all experienced childhood.
Yeah, we have. There, she's.
I rest my case.
Whoop, whoop, go, Dr. Beecham. I rest my case, she said. Okay, all right, so let's do the Kahoot. Now, I heard there's some issues with the Kahoot from wherever we're sending it. Can somebody explain that? Is there anybody that is experiencing issues with logging into the Kahoot or any of that when it's sent from the other site? No? Okay, I had people saying there were some problems with maybe seeing it. Everybody can see it? Okay, maybe it's that things that are everything's opening up at the end of the class, right? You're getting all the materials like the keys and stuff like that. Everything's opening up, right? Is there any other things that we're missing? No? Okay. If the couple people that brought this to my attention, write me and let me know if it's still an issue. All right, let's get started. I'm going to run the Kahoot from here because my password's working. I just had to log back in, and so I'm going to go ahead and run it from here. There's about 7 questions, just to get your brain thinking, okay? Get you guys awake, okay? Let's go. Hey, the music's back. It's so quiet last time. So very tired. I'm with you.
Me too.
I had to fly to Chicago yesterday, speak at a conference, and fly back last night. So I am pretty tired. I need coffee. And then I got here, and I forgot my wallet in my car, which is something that I do. But I ran into a professor who just said, "Can I give you some money?" I was like, "Yes." I'm not going to deny it. She was like, "You look so intense. Like, what's wrong?" Or intense. I was like, I just realized as I was going to get my coffee that I left my wallet in my car. She's like, "Here, let me pay that." Dr. Peridot said, "Let me pay for that for you."
Is that 2 different things, or is that like vodka in the night coffee?
Actually, Dr. Beecham, I thought about you maybe doing, a tap and go for me from Rochester, paying for it, and then me paying you back. That's how desperate I was this morning.
We need a slush fund hidden somewhere.
What did you say?
So we need a slush fund hidden somewhere.
Can we?
You know.
I have a donation, like a GoFundMe. I need to just get tap and go. And then I would just be, I would get with the, but then I'd have to explain the way that I like my coffee. And then.
It can be done.
It can be done. Oh, you'll have to show me. All right, got 52. I need about 15 more if we've got them all present. Who's small snack? What is this? Am I missing something? Is it Corey's like, Corey Matthews. It's Corey Matthews. This is what it is. It's who I am.
It's not
Got him?
You have an alias? An alias, I don't know. Just representing.
Okay, last time people logged in as us, so as professors, which was hilarious. So.
Oh, really?
Yeah. I had multiple people. All right. Looks like I'm set at 52. Got some people missing today.
Okay.
All right, here we go. Grief and loss, child maltreatment.
Get ready.
A perinatal loss is considered a stillborn at how many weeks gestation? We've had this before. You guys got tested on it. Remember that? Good, right? Remember, it's an interesting question, right? It's about the fetal tissue, so just remembering that it's a very objective finding with not a bunch of heart in it, right? It's before 20 weeks or after 20 weeks and how we consider what's products of conception or what we consider a fetus. So it's not a very fun thing to read on a report, but this is what it is, okay? So it's definitely 20 weeks, okay? 20 weeks, not about viability, right? It's not about viability here, okay? All right, Rita. Okay, true or false? Bruises on a 4-month-old are a normal finding.
You're right.
All right, those of you who said true, right, because the reason why, I remember her talking about this last week, the reason why this isn't true is because they can't run into anything, okay? So with a toddler, oh my gosh, all my kids had bruises on their heads, and that's normal finding. So if I were a practitioner and I had somebody come in like that, I would be more understanding. But on a baby, there's no opportunity for a bruise, okay, that they've self-inflicted, right? All right. All righty. Love chubby babies is in the running. A break in which bone is the most indicative of a pattern of abuse? Some of you said an arm. Okay. Who can tell me why it's the rib? You say it louder.
They're squeezing?
Yes, squeezing them, shaking them. Okay. Arms, not so much. Okay. Clavicles are a little really common in babies and so sometimes as a provider, that happens pretty easy on a birth, right? Normal thing, really. It's just a fast birth, the clavicle will break. But what happens is you get this one arm that's kind of lazy as a baby. They're meant to have arms that are up, and they have these really they're just to show their CNS is intact, right? Their hands go up and show us that they're exhibiting those cranial nerves. But one arm that's floppy, that's different. But however, in like a baby that's had that happen but nobody caught it at birth, they might come in and show us that. Okay, pretty rare to break a clavicle from an abuse. Okay, so most often if it's a clavicle and it's showing that the arm's not doing well, we know it's from a birth injury. Okay, so that's a good designator, but yeah, not the arm. Go ahead.
Good. No, I was going to say the other thing is when I read this question, I was the first thing that went through my mind was, well, what age is the child? Right?
Yeah.
There's no information here about what age is the child, and so then my thought process went to, well, overall, kids break arms, right? You fall off a bike, you break an arm. You do something, you break an arm. That's not an unusual, but how unusual is it for a child to break a rib? So that would be, if you get a question where it's like, well, I know what it would be in that infant, but it doesn't say it's an infant. So you just kind of have to think about what would be the most suspicious. And it would be that rib, right? Because basically you don't hear about broken rib. Anybody here just have a fall and break their rib?
Not often.
Arms or legs? So you kind of, when you don't exactly know a question, you have to look at what that question is asking and then try and think it through. So just another kind of test-taking strategy.
Right. Okay. Care. Somebody's named Care. Because you're caring? All right. If you suspect possible medical abuse, where do you start? All right, so you got to document first. So she was pretty clear about the documentation that has to happen, right? You've got to be able to document that this is happening over time. Okay? You have anything to add on that, Dr. Beecham?
No, but it is that documentation. You want to make sure that there is understanding. So, I can recall a situation where parents brought in it was a 9-month-old maybe with iron deficiency anemia. They were given a prescription for iron and did not understand how to administer it. And instead of giving, and I don't know what the order was, but instead of, say, giving 3 drops of iron, they gave the whole bottle at once and came in with the infant just vomiting and had to be treated for iron toxicity. But that was a clear case where it was not abuse, but these individuals just didn't understand how that medication should be delivered. So you want to make sure that education happens. There's a return demonstration, repeat of what was done, and then that's well documented so that if it goes forward and there is medical abuse, we can make the case that they can't claim they didn't know.
Right. Yeah. Right.
Yeah.
What is the best definition of mourning? Good. Okay. I was going to say that it might be confusing. So it's what's red? What's the entire process of moving through the loss of a loved one? Grief. Okay, grief process. All right. So those of you that picked that. But mourning is it's a public display, a way that we do that, and some cultures are really open about that, and some are not. Okay. Gordon's moved into the lead. True or false? It's never appropriate for a nurse caring for a patient with a 38-week loss to cry with the mom. I think this is a confusing one because we want to make sure that it's not our own grief that gets and sadness that gets in the way of helping that patient. But what you're going to find even in the birth of a child that's alive and the death of a child, right? That there's sometimes you're going to be overwhelmed a little bit with the sadness with them. And that's totally fine as long as you don't take away from it, from their experience, okay? You'll see this happen, and most people can empathize with you together as you know that this is something that's so sad you just can't, you don't know how to handle it. Some of us, the later the losses, they can be pretty devastating as a nurse, and so sometimes right after when this happens and they do all the work with that mom, and they usually sometimes as nurses we will then kind of have our own grief come forward, like start crying or something like that. And so we do allow for people to have some space and people to help people through that grief, through social work, okay, and some pastoral care services that we help with people, with nurses. So, and we try not to have those, many of them in a row, so that you can have some time to experience the sadness around it, not have to keep experiencing that. So we do trade on that. So these are tough losses, okay? All right, anything to add on that? Okay, last one. You are caring for a laboring mother of twins, one with an IUFD, intrauterine fetal demise, one living. What's the appropriate communication? So sometimes you want to say some of those things that might help them, anything that might help them. But again, all that therapeutic communication that we went over last week, and you had that form too that you could do, mark which ones were therapeutic or not, and you get to go over those, but most of them are pretty clear. Asking a question is better, right? Asking a question, how can I be there for you? How do I help you? Is going to be better rather than giving them a definitive about one or another. Okay. All right, I think that's it. Is that right? Yes. Jordan wins, pulls it out. Ditto, that one. All right. What we're going to do is we'll switch and transmit from the Rochester campus. So give us just a second and get started. Dr. Beecham's lecture.
So now we've learned about, turn the lights back on, I just do that.
You guys hear okay?
Is that okay?
We can see it fine,
What's
but
that?
we're having a hard time hearing you.
We're trying to adjust the lighting for everyone to be able to see the slides. And is that better?
Yeah, that's much better, I think, right?
Okay.
Okay.
I am in presenter mode. So if I review that, presenter mode checked. I don't know. Okay. Okay. So, as now that we're all set, I think we can all see the slides here, and you guys are there in Twin Cities, and you can see slides okay?
Yeah, we're great.
Perfect. So we're going to start talking about care of the children now. So we've had the laboring person, delivery of the infant, baby, and so we're going to start with that and go through really what we need to know about pediatrics and what we need to remember. And it builds on a lot of things you've already learned about in developmental psychology, in a lot of your other courses. We know how to do an assessment. We know kind of what the human body looks like and what it does. But what we also need to remember, and I guess this is a true-false question, children are not little adults. Is that true or false?
What do you guys think?
So we have a statement here that says, I guess that's true, but I think they are. And it's true. Sometimes we look at children and think that, oh, they're just mini adults or they're little adults. When we think about growth and development and how that changes from the time of birth through age 21 or 25, now we're looking at brain development really not actually, being totally matured until around the age of 25, there's an awful lot of changes and an awful lot of development and maturation that goes on within all body systems and within that individual. So we really need to recognize that children aren't really just little adults. They will become adults, but they really are different, and they have different needs, and they have different experiences, and they experience things differently. So we're going to look at all of that and look at it across the pediatric lifespan, and we'll look at how that influences us as nurses, what that means to us. And if you think, I never want to be a pediatric nurse, that's really fine, because if you all wanted to be pediatric nurses, there's not enough jobs. So take from it what you want. You may be a parent. You may be an aunt or uncle. You may just have friends that have kids, and to understand kind of that family dynamic and what's going on. You may be the nurse, and so you may be a geriatric nurse, but your next door neighbor has a 2-year-old, and they call you because you're a nurse, and they want to know, they have this fever, or they have something going on. So pay attention and take away what you can. And for those of you that want to be peds nurses, that's fabulous. And it's really, really fun. You don't get to be on a peds floor unless it's your immersion. But there is just a different feel when you walk on a pediatric unit. And I would say if you're in the hospital at some point, just walk through a peds unit and see what it's like as compared to some of our adult units, and see if it feels different. When I switched from adult to pediatric nursing, I definitely felt a difference, and it was a positive. So, not that I minded nursing adults, but I found my home when I was in pediatrics. So they're not just little adults. It shouldn't be unique, but I think sometimes it is unique, that when we're dealing with a pediatric patient, we know we are also nursing the family. It's really hard to separate that child from their family because they're so closely intertwined, right? The family cares for the child when they're not sick, when they're not ill. The family's responsible for their medical care. When you have a hospitalized child, that family is right there. And they will be watching your every move. They will be wanting to know what's going on, kept in the loop all the time. In a couple weeks, you'll do a simulation, and part of that simulation will be caring for a child with a parent in the room. So that can be a very unique experience, not unlike return demonstrations to your clinical instructor or your lab instructor, where somebody's just standing over your shoulder watching what you're doing. And sometimes we experience that in adults, and I think we should always include family. But especially with our pediatric patients, family-centered communication and family-centered care is one of the foundations that we lean on. So we want to have that family communication. We want to keep the family in the loop, and we want to answer any questions that family might have. So if we remember back to last year, remember the one question? If there was one thing I could answer, if there was one question that I could answer for you today, what would that question be? That's a really nice way to figure out where that family's concerns are and what we might need to do to answer and care for them in the midst of caring for the child as well. If you've got time for a more family-focused kind of an interview, that's great too. Are there kids at home? Are they concerned about them? But just that one question often can be really central in just having met the family needs as well as the needs of the individual patient that's in the bed. Developmentally appropriate care. I think it's kind of intuitively obvious that a 6-week-old, a 6-month-old, a 6-year-old, a 16-year-old, they're all going to require some different approaches when we're giving care because of their developmental age. And so we would need to remember that. And we need to remember to approach our patients, our pediatric patients, in developmentally appropriate matters. We need to kind of review all of those stages of Maslow and Erickson and things to understand why my patient might cry every time I walk into the room. Is it because they don't like me? Might be. But more often than not, if they associate me, maybe the uniform or whatever, with some painful procedure they just had, or a prolonged hospital stay, or things like that, that when we come into the room, the parent leaves, and they don't like that. So really kind of getting a feel for and remembering those developmental stages, because we will see those acted out, and we'll see them acted out in ways that are not necessarily typical, because anytime an individual's in the hospital, it's a stressful experience. And that goes for our children too, our pediatric population. So we really need to remember that this developmentally appropriate communication and interaction is important and crucial. Developing and maintaining a sense of trust, that rapport that we can create. So finding something that we can talk about that isn't like, okay, I need to give you your injection, and then I'm going to do this, and then I'm going to do that. Let's take a step back and develop a rapport first. With pediatric patients, what are some of the things we can do? Okay, so you could use some play, right? Typically, a child will have some sort of toy, game at the bedside, or be watching TV or something like that. I always found that was a great place to start. And if it was a cartoon or a figure or something I knew something about, I could say, hey, is that from X-Men or whatever, and try and get the child talking about something they enjoy and something they like. Or, I've never seen that before. Who is that? Where do they fit into whatever? But just to get the child comfortable, getting to know them a little bit, and you can then be gauging kind of their cognitive ability, how they're responding, and you can watch their body language. Are they guarding? Are they doing something that might look like they're in pain? Does it sound like they're in pain? When somebody's trying to talk, you can assess their respiratory effort. Are they talking in full sentences if it's a child that is verbal? So you can do a lot of kind of gross assessment while you're developing that rapport, and then maintaining that trust. And that goes for both the patient and the family. Maintaining trust, for children, don't say something's not going to hurt if you know it's going to hurt. If you say you're going to be back or you're going to find an answer to something and come back, make sure you circle around and complete that communication. Don't leave that family hanging. And a lot of times that's really hard when you've got several patients and you're pulled in many directions. But whatever system you develop to remember, I need to find this out and then I need to go back to the room. Or even oh shoot, I didn't find that out yet. Go back in and say, I don't have that answer for you yet, but I haven't forgotten you. That can just really do a lot to maintain that sense of trust. And remember to listen. Listening is a therapeutic intervention. And oftentimes we don't think of it, but we can find out so much from asking those very open-ended questions. Just like that, if there's one thing that I can either help you with or find out for you today, what would that be? That can open a conversation and gaining information from that individual that you would have never gained otherwise. And then just encouraging them, asking those probing questions if they say something, or just really through eye contact and head nodding and just an occasional, I understand, okay, just those kinds of words that encourage them to say more can really, really be helpful. So remember to listen and to make a goal to try and understand what it is that the individuals are saying, and try not, and it's really, really hard, but kind of a tickler for me is always if somebody says something and I'm thinking, oh, I know exactly what you mean. Well, I know what they mean because I've interpreted what they've said to a set of circumstances that I went through. And I don't necessarily know if that's exactly what they mean. So it's better to, in that instance, try and rephrase in your own words, and then say if they say, oh yeah, that's exactly right, or no, I really meant something different. So just really that active listening component can really be helpful in communicating with children and families. Like every good assessment. Question here in Rochester.
It's kind of off topic, but could we mute Twin Cities because it kind of messes with the recording?
Could we mute Twin Cities? I'm being told here it kind of messes with the recording when we have a lot of background noise.
Sure. Mike, did you hear that? Let us know if it gets better.
Okay. Well, I guess it's more with on the recording, not necessarily right now in the classroom. It's when they're looking at the recordings of the lecture. So we'll give this a try and just let us know if you've got questions in the Twin Cities as well. Any other questions about slide 1? So like any good assessment, we'll start with a health history. And the better the health history you get, the better we can care for people, the better diagnosis that can be made. So really gathering all this information is really important. And we will have families that say, I told the doctor that, I told, this person that, I told the nurse practitioner. We still have to do our assessment and our information gathering. And it's amazing how many times either we will learn something or someone else will learn something that wasn't told to anyone else during their storytelling. So a lot of times by asking people to kind of repeat their story, they fill in more blanks. And so it's really important to get that thorough history, the identifying information for our patient and family, who we can share information with, those kinds of issues around children, their chief complaint and a history of the present illness. So is this something that just started, or has this child been running a fever for a couple of days, or not been able to keep any fluids down, and things like that. Prenatal history. So we always want to get that prenatal history. What was that 9 months like in utero? How did the birth go? Were there any complications? That information, so the prenatal history and the birth history as well. And developmental history. So depending on the age of the child, have they hit their milestones? And we know that we tend to think, at 6 months they should be doing this, at 8 months or 9 months. But there's a range, right? Not everybody says, oh, I'm 6 months old today, I will roll over. Or, I am 10 months old, I will start to crawl. But you want to see the trend of development occurring in that child. We talked about that last year where, musculature, we see that it goes from head down and from inside out. So if we've got a 6-month-old that's learning how to roll over but not walking and not crawling, we're like, okay, that's appropriate, but they've got good head control. All 4 extremities are moving, and you've got good resistance and good play. They might be, trading an object from hand to hand. So they've got that center core and now are developing their outer nerve endings and coordination. We don't expect them to be able to hold a pen and write, right? That small motor development comes after. So just where they should be, what they kind of things they should be doing, and have they kind of hit those milestones. We want to know about their nutrition. So how have they been eating and drinking? What have they been eating and drinking? Is it typical to what they normally do, or is this different? Same thing with sleep patterns. And again, depending on the age, depends on what we would expect for sleep, right? Newborns, infants take naps, have periods, but so we don't expect a 3-week-old to necessarily be sleeping through the night. But we would expect a 3-year-old to probably sleep through the night. So just, how has the sleep been? Has it been different now than it typically is? So asking about a point in time, and especially during childhood where so much changes and so much changes so quickly, what is it like now, and is that typical, or has this changed, and if it changed, when did it change? Those psychosocial and behavioral factors. So how are they acting? You may have a patient who, when a new child enters the household, so there's now a younger sibling, or maybe the younger siblings are twins and are requiring a lot of care and a lot of attention, the older sibling might act out a little bit, or they might start to regress a little bit, or they might start to show some just behavioral issues. And that would be typical, as opposed to a child that maybe was verbal and was hitting all their milestones, and all of a sudden, with kind of nothing the family can identify externally, starts to regress and starts to kind of exhibit behaviors that aren't so typical. So those kinds of things. You want to know about spiritual factors, both for the family and the child, if the child's old enough to talk about their own spirituality. But are there any, groundings? Do they want, if it's a hospitalized child, do they want pastoral care? Are they notifying somebody to come in? Because with our pediatric clients, if it's a clergy we don't know, and it's not part of the family structure, that may be somebody we're not very readily going to let in to see the child. So needs to be good communications there. Cultural factors. What cultural beliefs, what cultural practices does your family have that we may need to incorporate into the care of the child? So getting all of those. Schooling. Where is the child in school? Are they at grade level? If it's anticipated to be an extended absence, is there a hospital school program that we might get them connected with? Or is their school going to be doing something? But where are they in school? Are they having trouble in school? Are they a good student? What's going on there? Sexual history, and one of the links is to the Tanner scale. So looking at their sexual maturation, where do they fall on that? For our adolescents, do they have a sexual history? And for our younger kids, was there ever any sexual abuse? What is their sexual history in terms of all of those components? And then the child's response to health care and hospitalization. So we would want to note, this is a child that's in the hospital frequently. He seems to know our system. He's known to us. We're known to him. Or, this child has never been hospitalized, nor have the parents. This is a new experience for all of them. The child seems very fearful, does not want the parents to leave. Whatever that response to hospitalization is, that can be part of our assessment. Questions? And then a family assessment. So we said about the one question that we can ask, but we also are really concerned when we have more time, and this might not all be done kind of right at intake, depending on what else is going on, but we could ask, what's the family medical history? So if we've got a patient, a little one that's got some cardiac anomalies, let's look at the cardiac history across the family. It's not infrequent for a sudden death to occur in our young athletes. We've all heard of those instances where there's somebody on a basketball court or on the football field and they just drop. And basically they've gone into VTAC. And with ACDs at all the events now, a lot of times they can be shocked and come back. But a lot of those individuals, when you look back in their family history, so-and-so had a relative that died young and early, and it was just all of a sudden. And so you can track some of those things, and then maybe once it's identified, there may be siblings or cousins that should also be checked out. So that can be almost like a screening tool for the family and trying to identify, are there family things that we need to know about in the medical history that could help us with this patient and also help the family maybe diagnose future instances of different conditions. A family genogram and structure is a good way to depict that. And that's that picture that then shows us. It also shows us that immediate family. So who's in their household? Is there a grandmother or an aunt or uncle or a grandfather in the house that's taking care of the other siblings? Or, what is that household situation? Is this a single parent? And what are the resources that they have access to? And the same with caregiving arrangements. Right, I don't know if you've ever seen a parent that wants to be in the hospital with their child and believes that's where they need to be, but is going to get fired from their job if they don't show up. And it doesn't matter, it doesn't matter if they have a doctor's note, doesn't matter, they will just be let go. And so that is a really hard situation. But if we can know that and document that, this parent's not here, but it's not because they don't care. Like, let's not make judgments, but the facts are, parent works 3 to 11, will not be here at nighttime. That's a given. Or has other children at home, not able to come to the hospital every day. What are those caregiving arrangements? Hospital school arrangements, we talked about that a little bit. Family coping. So how is the family doing? Now that you've got this child in the hospital, if we recognize, so the dynamic, right, the hemostasis of that family is disrupted. Right? You've got a child now that's taken out of the mix for a while, and as a result, also those parents need to change and alter and adjust what they do. Siblings need to, right? Now all of a sudden, the sibling I shared my room with isn't there at night when I go to fall asleep, and I'm afraid of the dark. And when they were there, I was okay, but now I'm scared, and now I'm not sleeping well. And so you can see where this could just really affect family coping, identifying family strengths. All families do some things well, and we need to recognize that and build it on that and build them up. Having a child that's ill, having a child that's in the hospital is a really, really scary condition. It's not anything anybody, even if it's a planned event, it's not anything anybody really plans for and how they will adapt. And so whatever we can do to help them build on their strengths and meet the challenges is really going to be effective in helping care for the family and care for that child. We want that child's health history, right? So we want to know their immunization history. And if you've watched the news at all, that's becoming more and more of an issue, isn't it? I mean, more and more we've got now legislatures looking at making it more difficult to refuse vaccinations upon school entry. So trying to stem the tide against individuals, children, adults not being vaccinated. Two of the stories I recently heard about, one was of a young man who, when he reached the age of 18, decided to become vaccinated against his parents' wishes, right? So he went all through life not being vaccinated, and he shared that, As I got to be more of a critical thinker and looked at the evidence, I wanted to be vaccinated. And so he became vaccinated. And then there was just another large study published, and I can't believe the millions of dollars we have spent debunking the autism vaccination link, but there was just another large study that was published that found no link between autism and vaccines. So we now have legislatures, like I said, looking at perhaps tightening down and strengthening the requirement or lessening the exclusion criteria for vaccines into entry into school. So that it would be more difficult for a parent to say, I don't want my child vaccinated. And we'll see where that goes. But that certainly is a nursing issue, and it's a public health issue, right? Safety measures. And safety with pediatrics is really developmentally tied in as well. We don't talk so much with parents when they're going home from the hospital about child-proofing their house, because that infant, what do we talk to them about? We tell them that your baby's going to start to roll, and the baby's going to start to roll when you least expect it. So never leave the baby on a bed or a changing table unattended. You will be taught if you're nursing or if you're changing a child and you need to turn away from the crib or the bed and the side rails down, that there's always a hand on the infant, even if you're not visualizing, so that that infant can't surprise you and roll off of whatever surface they're on. That's appropriate for a newborn going home from the hospital. But when we know they might start to crawl or they might start to cruise, we need to make sure the families know about other safety measures. Right? If we don't want the crib too near a blind that might have a U-shape cord. Children have been hung on that. We want the parents to actually get down on the ground and crawl and see what you see, because that's going to be your child's first visions. And so anything that you can get to at floor level or electrical outlets and things like that, that will then become part of child-proofing the house. Do you want your little glass figurines on the very bottom of your coffee table? Probably not. Number one, you're going to be really annoyed when they break. And number two, if they break, that can be hazardous. That child can get cut. So looking like that and maintaining safety. And then safety measures for our soon-to-be drivers would be really knowing about road safety. Not having, 80 million conversations, not driving and texting, or, having your cell phone to your ear, things like that. So there's safety measures that we want to make sure we give to families for health maintenance, but they do, drugs, alcohol, smoking. We're not going to be pretty much telling a 4-year-old about that, but an older child we will. We want to know about exposures. So if the family just had someone come over from a country where there is a measles outbreak or something like that, we would want to know about that. Did that child and family just travel somewhere where there was an outbreak of some sort, or where something else was going on? Again, we need to know about that. And the risk factors in parents. So, we are the products of our biological parents, our DNA, our gene structure, and I can remember at a certain age, one of my doctors said to me, well, what are you worried about? And I said that I've inherited all the bad genes from both my mom and my dad, so I'm going to have cardiac disease, and I'm going to have arthritis, and I'm going to need joint replacements, and I'm going to have asthma and allergies. And I just went through, like everything that they both had. And I said, that's what I'm worried about. I've got risk factors on both sides, and, it's like my mom and dad were great people, but I don't want some of these things to happen to me. So, what risk factors do the parents smoke? Do they realize that smoke can cling to their clothes? So, how are they managing their smoking and this child? So things like that. Any questions? Lots to think about. Not anything you don't know, though. But it's just a little bit maybe different context that we need to think about some of these things. Okay, so then we actually, after we get all that information, we probably have a pretty good idea of what we might find in this child. But now we're going to start our actual physical assessment. And we're going to take their respiratory rate, right? And how are we going to do that? I have a watch. I have a... Okay, we could listen or we could watch, right? If we watch that chest rise, or we could listen with a stethoscope. How long? I'm going to listen for a full minute. Somebody in Twin Cities, why would we want to watch for abdominal movements in the infant? Hello, folks.
To see if they're using accessory muscles.
Did you get that?
Okay, so now there's somebody talking and I can't hear them.
All right, we need to unmute Mike.
So we need the mic on for... Okay, we
Can
can
you
hear
hear
you now.
us? Yeah,
Yeah.
go ahead.
To see if they're using any accessory muscles.
Okay, so we would want to see if they're using any accessory muscles, right? Are there any retractions? What else do we know about the breathing, about infants and breathing?
It's
Newborns and... What's that?
It's irregular.
A little bit of regular. is what we're
Okay. I mean, initially, on birth, it should be irregular, but it should get somewhat regular after that. But yeah, our infants and newborns are abdominal breathers. So we're not going to, as with adults, we kind of see the chest rise. With infants and breathing, we're going to see more of an abdominal rise. So if we're watching, we're going to look for that respiratory pattern more as kind of the stomach going up and down, the abdomen going up and down, than it would be kind of the chest rise.
Right, and they're obligatory nose breathers, right? Why is that? Why do you think they breathe with their nose? You can tell me. What do they have to do right away when they come out and are birthed? Huh? Breastfeed. So can you breathe through your mouth and suck and swallow? No, so it's pretty cool that they really do not breathe through their mouth. You'll watch them. That's why we look for nasal flaring, retractions. Remember that one test question about the grunting greater than 1 hour? They can do anything for an hour. But after an hour, what? They can't. They're not allowed to grunt. They're not allowed to sing to us. They're not allowed to do any of those kinds of things that they do sometimes when they're in that sort of transient time. So.
And then the other thing with the abdominal motion, that you want to make sure that, and it's called a seesaw kind of a motion, and it would be an indicator of respiratory distress too. Mm-hmm. But it's where you kind of see motion in both the chest and the abdomen, but it's not like both are rising and both are falling. It's an uncoordinated, more like a seesaw, and that would also be indicative of some respiratory distress. Apical pulse. How long? Right, 1 minute. Right, and in our real little ones, it's going to be thumping away. Right, 140 to 160, that's a really quick heart rate. But you're going to take a good listen, and you're going to listen for a full minute. And again, it should be a fairly regular rhythm. Temperature. Yeah, and it pretty much is axillary. To get a core temperature, and we don't take rectals anymore on newborns for fear of rupturing or tearing the colon and anus. So, but if we do, and I think there's some pictures later on, if we do take a rectal temp, it doesn't need to go in, and we just need to make sure that we really are stabilizing the thermometer when we're doing that. About what age can we take an oral temperature for our pediatric patients? Any? Okay, yeah, 5 or 6. When they can hold it in their mouth they need to be able to hold it in their mouth under their tongue, and so be able to physically do that, number one, and be able to be willing to do that, right? They need to cooperate to do that. So if they don't like having anything in their mouth, if they think it feels funny under their tongue, and they can't leave that thermometer under their tongue for the time it takes to get the temperature, then I would go to another method. The most important thing is just to be consistent on the method we're using. Because unless it's a really high temperature, we want to see trends, right? Are they afebrile and they're still afebrile at 97 or 99, or is this temperature all over the place? Or is it rising? What's going on? So if we're taking an axillary, we're always taking an axillary. If we're taking an oral, we're always taking an oral. If we're doing another method, but just consistency as opposed to, well, this nurse felt like doing an axillary, and this nurse felt like doing a tympanic, and this nurse felt like doing the wand. I forget what you call those. But being consistent. When do we start taking blood pressures? And I'm more talking as an outpatient. As inpatient, we will take blood pressures pretty regularly. As an outpatient, we pretty much at 3 years old. Prior to that, we'll assess those brachial pulses, we'll assess pulses, but we won't be taking blood pressures typically at like a well visit. And you will get a whole lecture on pediatric pain, pain management, pain assessment and evaluation a little later in the semester. Dr. Susan O'Connor-Vaughan will be with us, and she'll give that. But assessing pain in kids is really important. Children feel pain and needs to be appropriately treated. And when kids are in pain, kids don't act like kids. When kids aren't in pain, kids act more like the children we know. So pain control in kids is really important, and assessment of that pain is really the first step in getting there. We know that, right, all of our systems are really immature at birth, right? So everything's kind of working faster. Your respiratory rate's faster, your heart rate's faster. The bladder's smaller, the kidneys and the liver aren't metabolizing and clearing things as quickly. So we need a maturation of all systems. Just on a gross kind of a gut feel, by about the age of 12, those vital signs approach more adult-like values. So by about the age of 12, the adult values you've already memorized for heart rate at 60 to 100, respirations 14 to 20, something like that. So by about the age of 12, that then becomes what the standard is. But you're looking at 140 to 160 at birth to 60 to 100 by the time they're 12. So that's a lot of growing, developing, and maturing of a lot of different systems that are going on as that child grows and develops. And we do need to know what's typical for what ages, right? So, if I've got a 4-year-old that comes in and has a heart rate of 125, is that okay, or should I be concerned? Well, it's less than 140, so at least it's heading in the right direction. and we'll look at those, but we really need to kind of at least have an idea of what those patterns are. And one of the tricks I use is to, we've got kind of a bunch of age milestones that we say, so for infants, newborns, that newborn period, 140 to 160, and then for the next period, maybe it's 110 to 140. I forget about that next period, and I worry about the next period, because if I know this one and this one, then anything in between is that middle period. So that's sometimes, if that makes sense, how I memorize less, but know because I know it's a pattern, and I know it's always respiratory rate, heart rate are always decreasing. So just some of the tricks that I've used in the past to kind of say, okay, what do I really need to know? Do I need to know all 5 or 6, or can I get away with knowing 3, knowing that the other 3 just end up in the middle? So, any questions there? So we've talked a little bit about the chest and the respiratory, what we look at. We do want to inspect, we want to watch, and we want to auscultate. We want to listen for those breath sounds, and realizing that on our infants, on our newborns and infants, and even toddlers, they've got really tiny chests and everything is really close together. You just look at the distance between the trachea and the lungs. Okay, so you're going to be hearing sounds that you may not be able to, but you'll be able to say, do they sound clear? Do they sound kind of, junky? And then, can I ask the 8-month-old to cough so that I can see if it's all upper airway, or, go blow your nose and cough and come back and I can listen again? I'm not going to be able to do that. So, maybe getting them upright and almost like a burping kind of thing, or just wiping their nose sometimes aggravates them enough that they'll also try and clear their airways. But really just taking a listen, documenting that rate and documenting what you hear, and if there's any wheezing or anything like that, you would be able to auscultate that. If you're not hearing breath sounds, that would also be obvious, and you want to listen side to side so that you can compare left and right lungs. Let's see what else I forgot. Yeah. Okay, so here we see, as I was talking about, the picture of that and the bifurcation of the trachea, how high it is, and then the separation of the trachea into the main stem of the bronchus on the right and the left. So it's up really high, which makes it really near the heart. And so you will have to really, really concentrate to discern the difference between those respiratory, to listen intently, I should say, because, breath sounds sound different than cardiac sounds, right? But when you want to listen to breath sounds, you have to listen for breath sounds and ignore the or whatever that heart rate is doing, and vice versa. I always had to close my eyes when I was listening to cardiac and lung sounds on little ones. It just seemed like I had to block out every other stimulus that there was in order to just really concentrate and hear those sounds. But you can see how that anatomy, little adults, but their anatomy is a little bit different, right? If their tracheas aren't as long, they haven't kind of grown and developed that way. So here are the standards for heart rate. And as we can see, between the ages of 1 and 2, average, and we know that average means that some will be above and some will be below, right? So there's that range of 70 to 150, but on average about 110. And then 2 to 6-year-olds, so they're down to about 103. 6 to 10, we finally get under 100. And so we've got, when we're kids, we're tacking away. We're just that metabolic rate and everything's kind of in hyperdrive, and we're just, but we need to understand what those typical are, so that if either they're tachycardic or bradycardic, we recognize that. And we recognize that that differs depending on the age of the child. Whereas with adults, we all are measured at the same standard, right? And then if somebody says to me, oh, I'm an athlete and I run and I do this, and well, then maybe your 50 beats per minute heart rate is fine, or 45. But if somebody says, yeah, I'm a real couch potato, it's like, well, why are you so bradycardic? You know, so really looking at what we know is the standard, having our patient, and then seeing where they are and how that might be interpreted, what that might mean, is really important. So in our infants, they're really not able to increase their stroke volume in their hearts. Their hearts are just pounding. So what can they, if they need to increase cardiac output, what can they increase if they can't increase their stroke volume? What's the other part of that equation? Their rate, right? So whenever anything funky's going on with them, they start tacking and tacking and tacking. And the thing with kids is they will compensate until they just can't anymore. And so it's not like with some of the adults that we see where they're fighting and fighting, and it's kind of like there's just this slow kind of, oh, they're not looking too well. And kids, you'll think, oh man, you know, they got a heart rate of 140. They're really compensating for this really, really well. And then all of a sudden they crash. And they just, it really is. So we really need to be careful about thinking that this compensation of being able to compensate with an increased heart rate, that's great, but it's not a long-term solution, because at some point they're going to punk out and they will code on you. And it will be pretty much without warning. So really being and assessing that and finding the root cause for that tachycardia, for that need to be so tachy, and treating that. And here we see where the apical pulse, the left midclavicular line, fourth intercostal space if they're younger than 7, fifth intercostal space if they're older. So just where to assess for the apical pulse. And again, is that that's not a very big adjustment to the head of your stethoscope. We want to make an assessment, which is something that will be done frequently, right? I mean, it's not like we assess you when you're admitted to the hospital and we're never going to assess you again. So we want that assessment to be in a place where the child's comfortable, where the parents can be, and if the child is being held by the parent, we can do a whole assessment with the child, an infant or toddler in the parent's lap. And that's not a problem. And the parent will work with us. And the child will be secure, and they'll feel, if the parents are calm, they'll feel calm, and we can make kind of a game out of it. We can listen to the parent's apical pulse, we can listen to our apical pulse, then we can listen to the child's apical pulse. Anything to show them it's nothing to be afraid of. We can, let them look at the stethoscope and play with it, or have one that they can hold, which is really a nice idea because it then occupies their hands and keeps their hands off of your stethoscope, creating even more background noise and things like that to contend with. But it really is a good way to do an assessment. And if that child is sleeping and you can get the stethoscope under their clothes and on their skin to do an apical pulse and listen to their lungs, that is golden. Because once a child's awake, they don't understand, can you be quiet for 2 minutes because it's really hard for me to hear your lungs and your heart? They're not going to be quite that cooperative. So if you can sneak in and do that, a piece of the assessment at least while they're asleep, warming up the bell of your stethoscope so that your hands it's not cold and going to wake them when you place it on their body, that can be a really good method. If the child's upset and crying, you might want to delay listening to their lungs until they're calmer. Okay, in adults, we say, head to toe, and this is the order you go in. And with children, it's a little more lax, right? Because you have to deal with them as well. And if you're insistent on listening to their lungs and they don't want that to happen at that point in time, you're going to need to listen to their lungs at some point. But if you can get them calmer and get them calmer about this whole process and then listen when they're calm, you'll get a better count. It will be easier. You'll get less resistance from them. So this is a really good slide just to remember that we can do an assessment in the lap. And we see two examples of that here. This is the picture that kind of depicts the different ways we can take temperatures. And as you see in the rectal temperature slide, what do you think is going to happen if I'm holding a child's legs up like that and then kind of inserting a rectal thermometer the way it's depicted here? Is that child going to just lie still? No. So, and they're going to wiggle their butt. So really, the recommendation is as you insert the, and forgive, I don't have a thermometer, I have a pen, but as you insert the pen, if this was the child's bottom, as you insert the thermometer, it just goes in a little ways, and then you cup your hand on the child's bottom, holding the thermometer, so if that child starts to squirm, your hand, and so that thermometer's not getting kind of jammed in or pulled out, you're going with the child. So that's the recommended technique for that. Any questions? Make sense that that's more what you would want to do? So we can take blood pressure at several different areas of the body. And this picture just shows you, there's a delay in the picture that now I've just noticed, and it really, I need to look at the slide, not myself. So you can just see the different areas where you can take a blood pressure. And typically, as in our adults, we would do we would assess the brachial artery. But if for some reason we're not able to do that, we could do radial, popliteal, or posterior pedal. And gotta say, brachial is the easiest.
Yes.
By far. So that just shows that there are, many, many areas that we can do that. So, and as I said, you do want to be orderly, systematic, head to toe, but you do have to have flexibility and work with the child. This needs to be done, bless you. But if for some reason they're kind of like, can you do this first? Sure, I can be flexible. If that's gonna allow me to get that assessment done, or if I can, mom might say, oh, or the parent might say, oh, I'll put the child back in bed. No, I can do it here in your lap. They seem to be happy there. Let's start there and see if we can't get that done, because that's going to make it an easier process for everybody. You'll hear talk later on about a procedure room. Procedure rooms are for procedures, right? They're for the things that are going to hurt, are going to pinch, are going to be uncomfortable, that we don't want the child to associate with their room. So for those types of interventions, we would take a child to a procedure room. But for a typical assessment, things like that, if we wanted to start an IV, we'd probably take them to the procedure room. But for just an everyday assessment that might be a little stressful, but it shouldn't hurt, it's not painful, at the bedside in the room is fine.
Dr. Beecham,
Yes,
can I say something real quick?
absolutely.
Well, this is one of those things with having as many children as I do, that I'm sure maybe your parents did this as well, but I would show up to their exams or their children exams and not tell them that what I knew was going to happen to them, right? Some immunizations, stuff like that, right? It's really, really important to not, this is not one of those things where you want to tell and have them be prepared, because children just do not understand that. They worry about those kinds of things. So oftentimes they would say, do you know if I'm going to get a shot today? And I would say, I don't know. I think we just got to wait and see. And then they'd be like, okay, but if I were like, yep, it's your 5-year shots, or you're going into 7th grade, right? I mean, they're just going to be terrified, right? Because they have that association. Do you remember that? How many of you had your parents tell you what was going to happen to you? Some of you guys did, okay. How many of you thought that was good? Is that good? You guys like that? As kids, possibly you did? Do you remember that?
Yeah.
But as teenagers, now, I mean, with Sophie, I'm going to tell her, she's 15, what's going to happen to her, right? Because she's old enough to know that. But little children are not, and so this is kind of something that you guys have to remember. Remember that key is, if it's a big procedure, take them outside of that room so they don't associate that. And if it's something that's minor or an assessment or something that's not, have it there, The one thing though, Dr. Beecham, is they do not remove little kids out of that room where they're getting their assessments for their shots. They keep them in there. And so how many of you waited and waited and waited knowing that you're going to get a shot for those people to come in and then give you the shot, right? I know they
So you're
come.
talking about in an outpatient visit?
Yes, in an outpatient
Yes.
visit. Yeah. We're talking about outpatient visits, yeah.
Yeah.
Yeah, so that can be terrifying for little kids. It's still, we had that this summer where they're waiting for the door to open and then have, their 3 shots being given to them. So anyway, just food for thought, but.
No, absolutely. In fact, I had a friend who was a vocal music person and a singer, and she developed the Disney song Skippity Doo Dah. I forget what movie it's from, but she would sing that with her kids every time they were getting vaccinated or any time they needed any kind of shot. So she was telling me the story, and she said, I would sit in front of them and I would take their little face in my hands and I'd say, okay, we're gonna sing. And she said we would just sit there, and so that diversion kind of helped her children with coping with getting the shots and things like that. I don't think I have the link today, but did I show it to you last year, of the physician giving shots to a baby, and he was using tissues and things to divert and to make him smile and make it a more positive experience. So there's a lot of different things we can do, but definitely, and especially like you say, a 3-year-old, a 6-year-old, you wouldn't want that anticipation. There's no reason that they need to know that they're getting an injection. But your 15 or 16-year-old, yeah, they have a clue that you know what's going on.
Oh, yeah.
So
and if you lie to them, that's considered lying. I mean, that would be just like, you're lying to me. Yeah.
Exactly. So I think it's kind of the parent assessing, where is my child, and when is it better for them to know, because they know I know, versus having it be more of absolutely for the young kids. You're spot on.
Yeah.
Yeah, and that's what I love about this class is Dr. Summerness, with her 4 children, has a myriad of real life experiences with some of the things we talk about. So, and when we were in the same place, it was easy to get eye contact and be like, okay, it's your turn to tell your story now.
I'll just interrupt you.
Please, I was going to say, please feel free, and just both classes need to know that that's going to be the way we work, because it's, I think, good to kind of hear real life examples, and that helps to solidify some of these concepts in our heads. So this is an intentional thing that we do that was probably a little more transparent when we were in the same spot, but thanks for interrupting. Always welcome. So again, getting started with the exam, we want to have it in a non-threatening space. Parents and caregivers can be present. Hopefully they are a calming force for the child. Sometimes we need to remind parents that they need to take a deep breath and just, talk them down a little bit so that they're not transferring their anxiety to the child. But most often, presence of parent or caregiver is a positive thing. Engage the child and praise them. So all kids like to be praised. They're doing great. Wow, they held so still for that, if it's a child that can. One of the things when I taught pediatric clinical, I would go into the room before my student, with my student, to introduce my student to the parent and the child, and I would explain to the child, and typically this was a school-age child, that I was a teacher, and this was my student. And just like they get grades from their teachers in school, I had to grade her, but I would need their help, because they were going to be the expert on how that student was by the end of the day. And so if they would pay attention, and it was amazing how astute some of these kids were about what happened in their journey of care for the day with the student nurse. And then you could tell kind of the ones that had a little bit of an evil sense of humor, because I'd walk in the room at the end of the day and say, so I had the student do. And this one little guy says, she did terrible. And the mother about dove onto him, like, what do you mean she did terrible? She was great. And he had just this grin on his face like, I know she did, but I'm going to say she didn't, and I just got you, Mom. But that was a way to engage him, and to engage him in his care throughout the day, and then to come back and kind of, how'd she do? Thank you so much. You did a great job, and that kind of thing. So any way you can kind of incorporate them into their care, I don't care how young they are. It's their care, right? And so they're part of it. And the more we can incorporate and get them to be part of their health care, the more they will, as they grow and develop, be part of their own health care. I don't know, have you seen the CDC growth charts? Kind of familiar with them? I'm seeing nods here in Rochester. But it's the way, when we have well visits for kids, one of the things we always do is take measurements, right? They're weighed, they're measured. And for the real little ones, we do length, because if a baby can't stand, we can't say it's height. So we stretch them out and measure from their heel to the top of their head. And then once they're able to stand still for like a stadiometer, we will take their height. And then a weight and head circumference. And then we plot those. And they're plotted against average standards for different ages. And it's not so much, is a child at 20%, is a child at 60%, but it's where were they the last two visits, and then as you plot, has this child all of a sudden jumped up, or has this child all of a sudden, they were tracking really well at the 60 percentile, and now all of a sudden they're at 40. What's going on? So really, that's the purpose of this. So every pediatric patient in their primary care office has a growth chart in their file. And that's really why we like parents to get a pediatric provider and stay with them, so that those trends can be followed and looked at. And if there is something going on, if there's a growth anomaly or some sort of thing like that, we can identify that more readily.
Dr. Beecham,
Dr. Summerness?
just wondering about a break.
Excuse me?
What are you thinking about a break?
I'm thinking about a break in 1, 2, 3 slides.
Awesome. That sound good?
Yeah.
We've had a few people getting up, so I just wanted to make sure.
Okay. So the general physical examination, and then as I referred to earlier, that can start when we're developing rapport, right? We're developing rapport with the child, but we're noticing their appearance, right? If they're playing with something on the bed and they don't have fingernail polish on, we're looking at their nail beds. We're looking at, are they pink? Are they, circumoral? What are their lips pink? How are they presenting? All of those kinds of things. Their behavior. Do they look like they're in any acute distress? So some of those, respiratory distress would be, that grunting in a newborn over the age of 1 hour, retractions, wheezing, those kinds of things, increased respiratory rate. Does it look like they're in pain? So are they guarding anything? Are they just not moving at all? Took care of a little guy who had appendicitis, that had an appendix that burst, had surgery, had some drains in, and it was just obvious to most of us that we weren't adequately medicating him for pain, because these tubes, when you think about where they were and what they were doing, that they would rub the lining of the abdominal wall, and it was painful to him, and he would just lie there in his bed and not move. I mean, literally, probably his hands more clenched and things like that, but just he didn't move his feet much. He didn't move. It was just like anything hurt. So watching for that. That's not a typical kid. That's not kind of a typical, and this wasn't, 1 hour or 2 hours post-op. This was 3 days, 4 days, 5 days post-op. And so really looking at that and evaluating and then advocating for your patient when you see things that are not as they should be. And again, our initial assessment, airway, breathing, circulation, any disabilities or different abilities that we would need to know about in order to adequately care for this person. Any exposures they had, we'd like a full set of vital signs, giving comfort, making sure they're settled, making sure parents are settled, then the full assessment. And we want to inspect all surfaces of the body, right? I think when Kim was here last week talking about abuse and how there was some very obvious evidence of abuse, but because that patient's area wasn't inspected, it wasn't observed on that initial assessment. So it really is important, as much as we want to keep the child warm and we want to keep the child clothed as much as possible, we do need to do a head-to-toe visual inspection of the body. And then we don't do an assessment of all of the cranial nerves on every assessment. But you do a gross evaluation of neurological status. And if you find something that's not as you would expect, then you go forward and do a more extensive evaluation of that area. So if we've got pupils that are reacting to light, if they're moving all extremities, if they're verbal, if it looks like if it's an infant, they've got a good suck and swallow, they're not choking on their food, whatever, we're basically seeing that, that looks like a pretty intact nervous system. And then we would go forward with our head and neck, chest, respiratory, cardiovascular, abdominal, genitourinary, reproductive, and noting the Tanner stage if they have started to develop, usually at the age of 10 or so. But we would want to check and document any because we do know that we know what the expected presentation would be, but if we find an 8-year-old with developing breasts, that would be a little younger than we would anticipate. We would want to note that. So we do need to check those things, musculoskeletal and integument. Questions? And after we do all that, we have to chart all that. Because we do know that it's not done unless it's charted. Any questions? Okay, why don't we take a good break since this was a rather long stretch. Let's start again at 10. Sound good? Okay. All right,
Yes.
Twin Cities?
They're excited. Yes, that sounds wonderful.
I appreciate their patience. Are you mostly back in Twin Cities, Dr. Summerness?
Iowa? I'm not going to put them on for us to
Most people back in Twin Cities, Dr. Summerness? I'm green. It's not easy being green. Sam? You have just about everybody back? Okay. All right, then, we'll get started. And any questions from the first bit that we covered? If not, we'll move on to the ill child, and ILL looks like it's the 3 child. The 3rd child in the hospital setting and other care settings, because the 3rd child is much more complicated than the first 2. No, the ill child. So kids show up everywhere, don't they? I mean, it's like they're in restaurants, they're in movie theaters, they're on airplanes right next to us or kicking the back of our seats. No, but settings for care for children is very similar to care settings for adults. Okay, there's not a whole lot of difference. We can see children in the hospital. They can be admitted for 24-hour observation. There are emergency hospitalizations, trauma, acute kind of incidents that require hospitalizations for children. There's outpatient clinics, there's day facilities, there's rehab facilities, med-surg units, intensive care. Across settings, we see children in really every area of the hospital. Some hospitals have special pediatric ORs, pediatric operating suites and things like that are set up specifically for pediatric patients. And they have programs that can allow for a easier transition from either the hospital bed or the pre-op area into the OR, sometimes even allowing one parent to go back with the child until maybe like an ether induction is done so that the child's relaxed and in a twilight sleep. Then the parent leaves and they will start the procedure and use some more of the intense anesthesias and things like that. So there's a lot, and those surgeons are, a lot of times it's pediatric surgeons, it's pediatric OR staff. Small hospitals don't have that ability to be that specific, but some of your larger hospitals, and definitely your children's hospitals, you will see these plans instituted for children-specific care. Some have things like wagons and little cars that the kids can actually go back to the area, driving themselves back and things like that. So try to make it very, very child-friendly. Some schools have school-based clinics that can see children while they're at school in order to ensure access and consistency in health care. There's also community clinics, and there's home care for children, and there is hospice and palliative care. And I know here in the Twin Cities, we also now have just opened a palliative care and hospice inpatient pediatric center. And so that area of care is expanding for our pediatric population as well. Talked a little bit in the first part of lecture about, how important remembering our growth and development of children is and how that might influence the way they react to a hospitalization or to, going to a clinic and things like that. For various reasons in my family, I received my pediatric vaccinations in quarter doses. So that basically means that for every 1 shot you got, I got 4 shots. Not at the same time, but so when I heard Dr. Summerness telling her story about her kids and wanting to know if they were going to get an immunization, I always just expected to get immunizations. And I can actually remember the first time I went to the doctor and didn't get a shot and walked out of there. And I can remember saying to my mom, like I got away with something, because I was like, they forgot to give me my shot. Like, let's leave. And she was like, no, you didn't need one today. And I was like, but I always, like, that's part of the deal. I didn't know really what to make of that. As an adult, I now realize what was going on, but it seemed like I was always getting shots when I went to the pediatrician's office. But recognizing, and some of these we may even kind of relate to ourselves, but realizing the common stressors related, that children can feel when they're ill and when they're being hospitalized, and that fear of the unknown. If you've ever been a hospital patient and been on a stretcher, being wheeled through the halls of the hospital, where you don't know where you're going, you don't know where they're taking you, you're lying down, which is a kind of vulnerable. That's not the way we go. We don't go through the world horizontal. We go through the world vertical. So you're lying down, even if the head of the stretcher is raised a bit. And you don't know where you're going. And then you've got this person behind you steering. So you don't know when the front of the stretcher is going to be turning. And for me, it was really disorienting. It was an experience that was like, this is really kind of weird. And I was an adult. I was a nurse. I knew hospitals. I knew the way things worked. And it was still like, wow, I'm just at the mercy of this person who's driving like a maniac and going, what I'm thinking is a little too fast, and it's making me a little dizzy. And so now you're 4 or 6 or 8, and you're in this place you've never been before, and there's all these strangers. And I mean, when you think about it, other than maybe going to a new school or going to a new church or something like that, this is the most adult strangers you're going to be meeting in a brief period of time, asking questions and wanting to know things, and none of this is familiar. So that fear of the unknown, and then like Dr. Summerness's kids, or like typically any child, is this going to hurt? What are you going to do to me? I think I told you about CHOP, Children's Hospitals of Philadelphia. Kids hear that they're going to CHOP. What am I going to lose? So that it's an acronym, and it's a very appropriate acronym, but that can instill some fear of, like, you're going to chop something off. Remembering that kids can be very literal. The little guy who was told he had a tick and couldn't figure out why he had a tick for so long because he hadn't been out in the woods. So just being conscious of these kinds of things. And then we know that separation anxiety is a real thing, right? It's a developmental for our little ones, toddlers and preschoolers. But if you've ever been in the hospital, I mean, there's probably a little bit of separation anxiety that we all feel, right? I don't want to be here alone in this strange place and have to go to sleep, and what are they going to do to my, and the more knowledge you get as nurses, the more it'll be, well, I don't know what they're going to do to my IV. I need to stay awake all night and make sure they don't mess something up, and we're horrible patients. We know too much. But in our pediatric population, the little ones, it's the separation anxiety from their parents. Our adolescents can feel separation anxiety from their peers. Right? Now, I'm in the hospital, and there's a big football game this weekend that we were all going to go to, or there's something important going on over break or whatever. And so that separation anxiety, not the same kind, but it's also a real kind of anxiety around being separated from what you know and want. Fear of pain, fear of mutilation. So what are you going to do? making sure that if the child's able to understand, they understand where that incision might be, if they're having some surgery, what it might look like afterward. We do a good job, I think, a lot of times with play therapy. And a lot of times a child can pick a doll out of a selection, and then that doll will have IVs placed like the child is going to have, and maybe a bandage where the incision will be, and things like that, so that they get somewhat prepared in a way that they developmentally can understand for what, when they wake up after surgery, might be going on. And that it's real important that this arm stays still, the arm with the IV, but the other arm you can move, or whatever this case may be, but can really, through play, help them understand what it's going to be like when they come out of surgery. So that as many questions as they have, we can kind of show them an answer. A lot of hospitals, if it's a planned surgery, have tours of the operating room so that the child can lay on a stretcher and look up and see those big bright lights and see, that that's okay, that's just what it's going to be like. And that, so that the first time they get rolled into that OR isn't the first time they're being exposed to all of that. And that it's going to be a little chilly, and we're going to get warm blankets for you or whatever. Loss of control. Being hospitalized, we take control away from everybody, right? I mean, it's our schedule, it's whatever we want. And we tend to, I think, even put that more on kids, because we expect kids sometimes just to comply to what we need, right? It's like, oh, you're just in the bed and I'm going to do this and I'm going to do this. So really trying to give them control where it's reasonable. So I think, offering choices where we can, but making those choices not endless, and also reasonable. We don't want to give them a choice they actually don't have. So if we need to give an injection, we can't say, do you want your injection? But we could say, do you want it before or after you take your oral medicines? Or we could say, if it's possible, do you want it in your right arm or your left arm? We can give those, do you want it here or here? We can give some choices so they've got some control, but we don't want to ask them if they want their shot. Do you want, because they're going to say no. And then we're in a corner that we didn't want to get into. And you'll do that. You will ask patients if they want something and they'll say no. If it's an adult, they'll laugh it off because they know that they have to have it most of the time. But if it's a kid, you've just given them a choice, and now they're going to be like, well, it doesn't matter what I say because you're going to do whatever you want. So you've kind of ruined that trust. Also, if it's going to pinch, if it's going to hurt a little bit, tell them that. Might hurt a little bit, but it'll be quick, or I'm putting some cream on to make sure it gets numb so it doesn't hurt as much, or I'm going to use this machine to find where the vein is so that I have an easier time of starting the IV. Whatever it is that you're doing to try and make it a better experience for them, you can explain to them, but don't say, oh, it's not going to hurt, because when it does, they're not going to believe you ever again. If you tell them and it does and then it passes, yeah, it hurt. Some things just hurt. I mean, we can't do some interventions without it hurting a little bit. That's just the reality. And so understanding their anger, and they might be angry, they might feel responsible, so they might feel guilty. They may think that they caused this to happen because of something, and so you want to try and relieve that anger and that guilt. And they may regress. So we may see some of those behaviors that we would associate with younger children in an older child. We may see more infantile type of talk in a child that has been talking in full sentences. We may be, see a child that is incontinent overnight and typically has been dry and totally toilet trained. So some of that could be in response to illness and hospitalization and a stress and coping response of theirs.
I have
Any
something
questions?
to add real quick.
Yeah.
Yeah. So if you remember, some of you, I've told you a little bit about each one of the kids, but Sophie, had an open meniscal repair of her knee last November, so a year ago, for a degenerative meniscus that it was, and she's a soccer player, and she had a perisynovial cyst that came to the, inner side of her knee. And anyway, long story short is, long surgery, 2.5 hours. Like I said, most meniscal repairs are done orthoscopically. Hers was, she was opened up, and I mean, pain like you have never, I've just never seen anything like this. Even the nurse came and got us. She needs you right now. Like, she's hyperventilating. I had got with the anesthesiologist who had told me that he probably should have done a femoral block on her before he started. And so and the nurse was like, I gave her some pain meds, but it's not working. And I said, well, it's mostly she's just in complete fear and out of it, right? She was so out of it. Long story was, we got the femoral block. Took us about an hour to calm her down. That time she was just 13. But then last May, after 6 months of PT, she found out that the other knee had the exact same injury. So again, really weird. We gave her summer, and we had to go forward to do this surgery again. And so here's this kid who is, all she can remember is the pain pathway, really fearful, regressed. Literally, if she could have had me in the surgery holding her hand, she would have done that. So, I mean, I'm being a nurse and an advocate, which is what you guys are. So if you ever have a kid like this or has this memory of pain, you got to do your best to try to get them to go under well, because they'll come out pretty scared again. And so what we ended up doing is doing the femoral block early while she was still awake in the room, which is anybody received any sort of pain medicine like that, or a block? Anybody? You have. Yes. So do you remember it?
Yeah.
You do?
Like, stab me in the groin.
Yes.
Like 3 times.
Yeah. So this is not a fun.
It's a big needle.
It's a big needle. Of course, she didn't remember it the first time, but they gave her Versed, trying to get her to, and she was just so tearful. Anyway, long story. So this is this whole big thing. She's still, because of everything that went on prior to the memory of the pain, even though we numbed her up, she still came out of it exceptionally combative, just so out of it and so stressed out from it. And so I share that with you because this is very true. And so some of if you go into peds, you got to understand how to help them through it, through being, as calm as you can, but also knowing that, yeah, this is going to be painful, but this is our next best option for it. Because what happens when you're in a lot of pain for a few days after your surgery? Do you heal well? You don't. Your brain is just not forgiving. It's not. And so getting people in a good, especially for those 3 days, I mean, first 3 days after surgery, if you can get them relaxed and their brains calm, and then wean off all that stuff, it's really good. So anyway, share that because even as a mom who's done this for a long time, it was pretty tried and true to what Dr. Beecham's talking about. This is big stuff, so, and hard stuff. So putting that together.
Yeah.
Yeah.
And the other thing, do you folks do an OR rotation anywhere along the way, OR PACU? Kids come out of anesthesia differently than adults do. That's just one of those weird things. But adults kind of wake up very gradually, groggy, and just kind of, come to. Even when it's not a pain issue, as it, was in Sophie's condition, but kids wake up from anesthesia combative, and it lasts maybe 5 minutes if it's not due to pain or something else. But if you're not ready for it, it is the most. Does anybody have an experience with that they wanted to share? Yeah, here in Rochester.
Both of my daughters had tubes in their ears, and when they wake up, they're just, I don't know, like inconsolable, and I don't know, just hard as a mom to.
Did somebody warn you that would be the case?
No, not really.
See, and this is where I think sometimes we drop the ball, because it then was harder. Whereas if it's like, you know what, we're going to want you back here, because typically kids are either, really wild and just, it looks like they're in pain. It looks like pain, and it's the hardest thing to watch. But if we at least tell you, this is typical and we're going to keep an eye on it, but we're not going to react to it in the first 5 or 10 minutes, then you as the parent can deal with it differently than just like, why aren't you, and then somebody say, oh, that's, all kids do that. Well, if all kids do it, why isn't that part of our pre-op kind of review with parents?
When like knowing that was going to happen.
Mm-hmm.
I don't know, first time mom, you're like a mess anyway.
Yeah, well, I was a nurse. I mean, nobody told me. And the first time I was floated to a PACU, a pediatric PACU, and saw this, definitely, I know, wide-eyed and like looking around like, why isn't anybody? And then it was explained to me, but I had never heard that or realized it. So just another difference in the way kids react to medications versus adults. And so we have to be aware of those and, help the families in dealing with that, because it is a bizarrely scary thing to it's like this child's going to jump out of the bed, and that can't be good, and I don't know what to do because they're on medications and stuff like that. So anyway, there was something else that crossed my mind, but if it comes back, I'll let you know. So separation anxiety. It is common, and typically it's a time of protest. The child's aggravated, agitated, doesn't want that parent to leave, is inconsolable, cries, and then we see it in our kids with daycare, right? If any of you have had children and had to take them to daycare, some kids go off fine and other kids are just like, nope, I don't want to be here. And then you call back in 15 minutes and it's like, oh yeah, they're playing. But that separation anxiety and that fear of being separated causes that child to have a reaction. And so for our hospitalized kids, we recognize that as normal. We try and deal with just the family and the child and explain that, that parent will be back maybe after they wake up in the morning or after they have dinner if the parent had to go home for a period of time during the day, or whatever the situation is, and then maybe get a child life support person in there for the child during that transition or whatever we can do. But children will express some separation anxiety, and then it goes away. So, and it may, wax and wane, but that's kind of that stage. The despair stage is one of a little bit more concern, and we might be fooled in thinking that, oh, the child has adapted to the hospital, because now when mom or dad or their caregiver leaves, they don't seem to even pay any attention to it. Well, when you think about it, that's probably not normal either behavior for that child. That child would probably want to say goodbye to the parent and see them off and then come back to whatever they were doing. But in this stage, the child really feels hopeless. And so their way of separating, if you want to think about that, is to kind of just remove themselves a little bit emotionally and become more quiet and withdrawn and somewhat apathetic. So they're not going to be as involved with their environment and things like that. So it may, to us, look a little bit more positive sometimes because, oh, thank goodness, they're not crying and screaming and trying to chase their parent down the hall when they're leaving. But it really is a more severe reaction to that separation. And then detachment is that total kind of, well, fine, if you're going to go away, then I'm not going to pay attention to you when you come back, and I'm just totally, this is my new environment, this hospital environment, and that's what I'm going to pay attention to. So there would be less less involvement and engagement when the parents do come back. And again, none of that, you wouldn't see any of that separation anxiety. So that's kind of the stages and the things that we look at. So actually that resisting caregivers, us as caregivers, the healthcare caregivers, wanting only the parent there and things like that would be the first stage. Questions? Yes.
Do they move through those 3 stages as like time goes on, or is it kind of like they're in one? Yes.
They could move down, but it also depends on their coping mechanisms and how it's handled and kind of what they're doing. We would be more concerned if they were in either the despair or the detachment. That's a less positive coping mechanism. So crying and expressing your displeasure is kind of normal. And depending on the age of the individual, that may be their only way of showing that displeasure and frustration that their parent has to leave and that they don't want to be separated. So that can be a very typical and expected kind of a part of separation anxiety. And some kids don't have separation anxiety. They have a sense of they're leaving, but they'll come back. And, this is how it goes. I had a little guy in the hospital who was about an 8-year-old with sickle cell. And he had to come in fairly frequently. And mom lived about 30, 45 minutes away by train and couldn't get there often. So he, although he loved it when she came and visited, the interaction between them was very positive, things like that. He understood and was of an age where he also understood when she needed to go away and that they would talk on the phone that night. And so he had a sense of comfort and security even though she wasn't there. So it would be working towards creating a plan that did that for kids that were experiencing separation anxiety and not having it develop into something else. Any other questions? So with our infants and toddlers, when they are hospitalized, some of the stressors that we would associate with this age group, and so we're thinking about newborn to about 3, right? If we're thinking toddlers, so we would expect that they would experience some separation anxiety. It's a new environment for them. They are, when you think about their development, they're realizing they're separate from their parent, right? That between infant and toddler, they realize that, oh yeah, mom and dad and brother are not part of me. We're separate, and I'm here and they're there. And in developing that autonomy, well, then to be separated may create some separation anxiety. So when you think about what you know about your kind of psychology, developmental theories, you can tie in and see how some of this plays out. Fear of pain and fear of injury, right? We don't like to be hurt. We don't like to be stuck. We don't like needles. We don't want to get IVs started. If it's a traumatic injury, whether it was a fall from a bunk bed or and it's a broken limb or a laceration that needs stitches or something like that, it's a scary thing. And now my arm hurts. I don't want you looking at my arm, and now you want to take an x-ray. And now you want me to hold it in a... So when I was, I don't know, maybe I was 5, I fell off a bunk bed and got a fairly good laceration here. If you know anything about heads, lacerations bleed like crazy. So I had to go to the OR. Of course, we're on family vacation. Evidently, as the story goes, I do not remember this, but as they were carting me back to wherever they were going to do the sutures, all I was doing was screaming at the top of my lungs, "Daddy, Daddy!" And it, my parents would talk about how that broke my dad's heart that he couldn't go back with me and comfort and do what I wanted. And I was just did not want to, fear of injury, fear of pain, fear of being separated, and like, where are these strangers now taking me? I'm sorry I fell. I didn't mean to, and whatever. But so just realizing that that's real, and we need to deal with, and that's why family's so important, right? Because they took me back, and now my dad's like, my daughter's screaming for me, and I can't do anything. Like, they told me to stay out here and wait. And then they gave me this really good blue medicine that calmed me right down. And a loss of control, right? Because now I can't have the pancakes that Mommy always makes me for breakfast. You're going to tell me I can only have cereal or something else, or I can't have whatever. And, my daily routine, and when you think about infants and toddlers, routine and rituals are very important. And now we've just gone, nope. This is now our schedule, and this is your bed, and this is how you're going to do it. And we're going to wake you up, and we're going to do loss of control. And when you think about toddlers, what are toddlers trying so hard to do? I can do it, right? They're trying to gain control. And now we've just taken it all away from them again. So really very, very realistic for that infant toddler period. And we need to consider that and work with them. The preschooler. So the preschooler, as they're getting more out into the world, they realize that mom and dad leave, but they come back, or I leave and then I come back and we're together again. However that works, separation anxiety is less obvious and begins to subside. It can still be present, and if they regress, it can still come back, right? So we're not saying it's gone, but it should be resolving itself. Fear of injury or pain, especially the fear of mutilation. So they really are afraid of losing a part of their body. They don't want to have things taken away. That's sometimes why toilet training can be so hard, because that's part of me, and now it's there, and they just resist. Some kids just resist that. So everything that's mine I need to keep, and I don't want to have any of this happen to me. So understanding that fear, understanding it in terms of the language that we use. If we tell kids they're going to get a shot, with all the violence in the world today, what might they think? They're going to get shot. So let's not use that word, right? But we will always say something that can be taken literally, and we just need to be aware of when that might happen and ask a child what they're thinking or what they think is going to happen, because they will tell you, and they may tell you the best story in the world that has no basis for reality, but you can give them some then just, like, well, let's show you, let me show you on your doll what's going to happen, or you're still going to have, this, and so we can work with the child to try and minimize that fear and anxiety. We can work with the child to try and give them coping mechanisms to deal with pain, like singing zippity-doo-dah with your parent, or, let's get a joke book. And while we're doing this, I want you to tell your mom or your dad 5 jokes that you learned, or what was your favorite one. Any kind of distractions. Some places, if the child doesn't need their hands, will give them video game. Listen to music, put on headphones, whatever works. Whatever can help with that. Again, that loss of control and guilt and shame. So the preschooler may have that, fantasy thinking, and they may think that this is something that they wished and they wanted to have happen, or they may tie it to something else that happened the night before. This is my punishment because I spilt my milk last night. And so now I have to go to the hospital because I was bad and spilt my milk at the dinner table or something like that. No correlation between the two events, but kids make correlations and make connections where there aren't any. So if they're doing that, we need to kind of help them work through and understand that that's not what's happening. Maintaining a safe space. So we talked about how the child's room is pretty much a safe space for them, right? That's where we want them to sleep. That's where we want them to recover. That's where we want them to be a kid. So maintaining that room as a safe space. But also then there's an even safer space in a lot of children's hospitals. And I think even hospitals that have a floor or two for children, and that would be a playroom. And so a lot of hospitals have playrooms for children that have arts and crafts and maybe a book library or a video library or child life therapist, maybe a music therapist, different kinds of people that can work with children to help them have fun and explore in an environment where they know they're safe. No procedures to include assessments. So it's really a safe space. If the child needs to take a pill, if the child I need to listen to their lungs, we need to leave that room and go back to their room for a minute or two, do what we need to do, and then they can go back. No white coats. Right? It's a safe space. So that really is a way that a child can relax because they know nobody's going to sneak up on them and say, oh, I just need to. And this is an entirely, they can just breathe and be a kid. The rest of that, I think we kind of went over. Intrusive procedures take place in the treatment room, but assessments, administering medications or treatments can be in their room, not in the playroom. So here we've got a 18-month-old who's been hospitalized for 4 days. And he's crying inconsolably when his parents left, and he refuses the staff's attention. Now the nurse observes that Eric appears to be settled in and unconcerned about seeing his parents. The nurse should interpret this as he's successfully adjusted, he transferred his trust to the nursing staff, he may be experiencing detachment. Because he is at home in the hospital now, seeing his mother frequently will only start the cycle again. Right. Twin Cities, what's the consensus there?
You hear us C.
Right. Right, because we know that that's not a typical normal adjustment. We would expect, what would we expect if he was typically adjusting? He'd be playing, okay. What about when he sees his parents?
He'd be excited seeing him.
Right, there would be a reaction, and he would be welcoming them back into the hospital, and he'd be excited to see them, not unconcerned.
In that case, you keep that child with the same nurse throughout the whole process, so because of the trust factor.
What you would want is to get some other folks involved in, like, how can we get this child, because he shouldn't be trusting. He should be trusting, but he shouldn't have transferred that nurturing parental role to the nursing staff, which is what's happened here. So you need to trust your nursing staff, but he shouldn't be, or the child shouldn't be like, yeah, I don't need my parents now because I've got Barbara and I've got Corey and, we're good. So that's the problem, is that the child has transferred that where he's looking for that care and guidance and nurturing. Because we're not going to be there the whole time. Question here in Rochester.
Yeah. So what would you do to help him cope a little bit better with his parent? Like, what can you do as a nurse?
So I think that depending on where the child is, trying to give some sense of when they'll be back, when they won't. If there's objects from home that he might have at his bedside to kind of keep that connection. 18 months, we may do a video chat if they can't come in, but he could at least hear their voice, and they could let him know after you eat dinner we're going to be, or whatever. So are there ways, and especially now with technology, there are a lot more possibilities that may exist, and you just need to explore with each family. So it's more, and it's catching it earlier, right? You don't kind of want to go, oh yeah, he was a maniac for 4 days, and look at how nice he settled in now. Well, if we did nothing for 4 days, that's on us, because we saw that, and we saw that he was having this anxiety and adjustment, and so there should be a plan of care to try and address that. School-age children now, as opposed to separation anxiety, they just are upset, distressed, whatever word you want to use, about being separated from family and peers. More of an older child reaction, when you think about school age, they're very industrious, and so they want to be involved in the things at school. They're I've got this to do, and I have this to do, and things like that. And so being separated from that and being away from your schedule can be distressing to them. They have more understanding of bodily harm and are developing a better understanding of what it means to die. So this could also be a fear, and certainly one that can be addressed. And what are you thinking? And what's a good outcome of this hospitalization or whatever? Just to assess where that child is, and see where they are, see what they are thinking about. They will ask relevant questions. And this is a group that I would say the question might really, really be relevant, but don't go off on a really, really lengthy explanation. This is one where if they ask a question about their surgery or the medicine or whatever it is, well, tell me what you're thinking. Tell me what you know about it. And so you can get an idea of what specifically they're asking about, and the kind of stereotypical example is the child that asks where babies come from, and you go through this whole lengthy explanation in detail about how babies are born and what goes on, kind of like Dr. Summerness gave you over the last 4 weeks, detail after detail. And they know that baby, where did they come from, like the cafeteria or the playroom? That was all they wanted to know, but you just gave them a lesson in childbirth. So really understanding what their question is at this age is really important, because you don't want to kind of kill them with facts that they're not even thinking about or have no ability to really comprehend. They will want to know the reason for tests and procedures. So, why do I need this? Yeah, I'm not going to say no, but what does this do? So some basic just explanations about what's going to go on and why we're doing this can really help them understand and be more cooperative, because now they've got some information. Adolescents, again, separation from their peers is a major source of anxiety. And again, technology can help with that connection. As more and more people have smartphones, iPads, and the like, those communication vehicles can help adolescents feel more still part of the group, although they still may be distressed that they're missing events. So if there was a big party, if it's prom season, if they were supposed to be in the school play, if they're a football player, and there still may be a lot of anxiety and stress around having to miss those, but hopefully they can still be part of that peer group. Again, loss of control and fear of injury and pain. So our littler kids, once you take their pain away, they'll pretty much do what you want them to, and they want to. I mean, your kids that have had surgery, if you take pain away, they want to be out of bed. They want to be in the playroom. They want to be getting back to their life and their normal activities. As adults, it's going to hurt. You want me to get up? I just got out of surgery 3 hours ago. You got to be crazy. I'm not going to get out of bed. How many have had an adult patient that has been really apprehensive post-surgery of getting up and out of bed? Right? We know what pain and injury feels like, and we don't want that. So we actually do ourselves harm by not just trusting that it's not going to be. You know, a child's going in is like, oh, it's not going to hurt. Once it hurts, then they're going to be like, oh, that might hurt again. But you take away their pain, and they're like, yep, I'm to the playroom, I'm good, I can do this. And we almost have to hold them back. Our adolescents are more adult-like, right? They're more like, this is going to hurt, I don't want to do this. I can remember we had a young man who had a horrendous diving accident. Night after prom, group went to the shore. This is in New Jersey. Took a dive off of a pier and neck injury. Fortunately for him, part of the group he was with were lifeguards. So his friends immediately stabilized his neck, called 911, got help. He got surgery, and he was doing okay, but he was having a lot of fear of moving, of re-injuring, and things like that. And I was working on the unit, and this one day, all of a sudden, I hear this, dude, you got to get out of bed. I'm like, what? And this person is yelling at this kid. And I'm like, what the heck? And I go in, and it's his neurosurgeon. It is his neurosurgeon who's like, I did not operate on you and save you and save your neurological system for you not to be getting out of bed. Because if you don't, you are going to lose your ability to walk. But he was literally like, the whole unit was like, dude! And the kid ended up walking across the stage at graduation. But, you know, he was fearful. He didn't want to move. He didn't want to get up and out of bed. So sometimes we need to, you know, understand where our patients are and help them over those hurdles. And maybe it's by letting the neurosurgeon holler at them. So factors affecting the child's response to hospitalization, the perception of events, and I think Sophie is a really good example of that, right? She went into the first thinking it would be okay, but because that first experience was so traumatic, then her perception of what future events would be like were based on that. We see that with pregnant women or with individuals who are having subsequent children. Right? My next pregnancy is just going to be like my last one. So if I had an easy delivery, I expect this one, or vice versa. I think that's true, Dr. Summerness. But we do kind of base our future expectations on what our prior experiences have been. We really need to pay attention to age and developmental level. Cognitive ability. What is, you know, where is that child cognitively and what can they understand? How can we best prepare them for whatever it is that needs to come next? Whether it's surgery, whether it's placement of an IV, whatever that intervention is, how can we prepare them? What is their previous experience, right? If we don't know that Sophie had a prior experience in the hospital and had such poor pain control during that post-surgical period, we may not understand her reaction currently. So if there's information we can get about those previous experiences, what kind of coping skills do they have? And what are the parent and family responses? Because we know, especially with our younger kids, as the parent and family goes, so goes the child. If the parents are very confident and this is, you know, what we need to do and we go forward, versus a parent that's really anxious and is just expressing, you know, well, will this be okay? And that child's going to have a lot of anxiety and uncertainty also if they overhear that. And kids pretty much hear everything that goes on and interpret it at whatever cognitive and developmental level they are. So we need to be very aware of that. I've had end-of-life family meetings with all children, to include the 10-year-old who was dying of cancer, in the room, and that's what the family wanted. And the family was very open and said, you know what, we always have family meetings about important things, and we've always involved the children, and this is a very important life decision for our family, and they all need to be here. To parents that say, I don't want my children to know anything about this, and so you've got the parent or parents in a separate room having a family meeting. And we can do it a lot of different ways, and you just work with everybody to what's best suited for that patient and family.
Yeah, and I'll just add that it's pretty, this is a hard thing to do as a parent and as a, you know, you guys are all going to be practitioners as well. And so when you're advocating and you've got somebody else telling you, well, this is not how we usually do it. So in the case of Sophie, the anesthesiologist didn't know what I did, only saw me as the mom. I didn't explain any of my background. And he was an interesting guy. And he asked me, I said, we really need to do this because, I was in the room with her because she is so terrified of waking up the same way that, you know, I'm afraid that this is just not going to be good for her. And he was like, well, you know, we don't usually do it like that. We wait and assess those kinds of things, pain level. We give her stuff, you know, while she's out, blah, blah, blah. And I said, well, no, that's not going to work for today. It's just not going to work. And I had her, and he said, well, let's step out of the room so that, you know, we can talk about this. And I was pretty adamant that if I would have stepped out of the room, that would have increased the anxiety for Sophie. I had to stay in there and advocate in the room with her. Me leaving that room would have been just horrific for her. So it's interesting, you know, and I know enough to say, yeah, no, I understand this might not be the way that you usually do it, but for her, we're going to have to do this before. And so just hanging with the tension. You're going to do that as a nurse too, for advocating for your patients, saying, I understand this might not be how it's usually done, but we're going to have to think through a different alternative because this isn't going to be good for her if we don't.
Right.
Okay. Great. That was a great topic, Dr. Beecham, because this is advocating and what's best in the room rather outside of it. And, you know, the pendulum has switched. We used to not talk about things in the room. Remember I was talking about those complications? We used to like hem and haw over a shoulder dystocia or a cord, or kind of say, well, we've got a big issue here, but not explaining exactly what's going on. And all the litigation tells us that's just not good for patients. They want to know what's going on right then. So.
Yep. And then what are those child's coping skills? So I think last semester I shared about my friend who's got the 4-year-old who had major cardiac anomalies, and he's had like 4 cardiac surgeries and been hospitalized several times, and they developed a script to help him cope. And what they do is, for him, he wants to know every step. And so, you know, well, today you're going to need a ultrasound of your heart, and they're going to check your pacemaker, and they're going to do this. And one of them, he said, well, do they need to draw blood? And she said, you know what? I don't know. Let me find out. She went back and, you know, kind of asked and stuff. So his way of coping, and definitely a kid that has been major hospitalizations, For the first probably 4 years of his life, the longest he'd gone without seeing some sort of a doctor was maybe 6 to 8 weeks. He needed to develop a lot of coping skills around this because he had a lot of very invasive procedures done, cardiac catheterizations, a lot of things. So this script helped him know what was coming up, and she was advocating for him quite a bit because he had a procedure done, something on his ears, and they wanted to sedate him. And she said, no, let's try this first. And they were really resistant, and she was really insistent. And they went through the script, and by the end of it, they were like, can you share this with us? This worked really well. And she's like, yeah, but it's not going to work on like just bringing a kid in and thinking they can do it. This has been years of work in giving him coping skills. So it's what has they, do they sing zippity doo dah all the time? Do those kids and kids and parents have coping skills that help? We know that play is the work of childhood, so we want to give all of our patients an opportunity to play. And so that's really, whether it's, if they can't leave the room, we bring things to them that they can play with. If they can get to the playroom, even, we've taken beds to the playroom. So whatever it takes, if we can get that child to the playroom, there's therapeutic play. There's music therapists that a lot of times will come in and play and sing and do things like that. Teaching through play, some of the examples like the OR prep and things like that. What's going to happen in this procedure through showing them on a doll can really be helpful. Play as an emotional outlet is fabulous. You can't hit your nurse, you can't hit your mom, you can't hit your brother, but you can hit the pillow. And so, how can we get them to express their emotions? You're not going to tell me, can you tell your doll? Pet therapy. Pet therapy, I think, is as good for the nurses on the unit and the people on the unit as it is for actual patients. Play can enhance cooperation, right? If I'm going to be playing with it, I can be doing some of my assessment while we're playing a little game or doing something silly, and then just giving them unstructured playtime. So, what they can learn through that. And so here we see a child who, in some traction, not getting out of bed, but has a host of activities there. And it looks like he actually is in the playroom because the other dude here is playing basketball. And so there are ways we can, with a hospitalized child, still give them an opportunity to play and be a child. Admitting a child in the hospital setting, very similar to what we said about initially as outpatient. Taking a good thorough history, what happened, why did they come to the emergency room, or why are they being admitted, what's the understanding. A lot of times it's the parent that's giving this information, but if you have a child that's able to talk, I would ask them first. And I sometimes will tell the parent, you know what? I know you know. I'm just trying to understand, too, what your child knows and understands about this, so that if there's any miscommunications or misunderstanding, we can uncover that. So we take the history from the parent, but include the child as much as possible. And then that physical examination, the baseline inspection, again, all body parts, baseline data. The other thing we do within pediatrics, and especially with our younger children, is we allow and encourage the parents to be as involved as they can and want to be. So, if the parents want to bathe, change diapers, do things like that, that's great. If we're keeping strict I's and O's, we teach them that, we weigh the diaper, you need to save it, because that's how we know what that child's output is. If it's a diapered child, that we need to weigh that diaper after to get the volume of urine and feces or whatever. So we can train them, and then we can let them do some of the care that they want to do, because it's very difficult for a parent to give up, because that's part of their parenting role. That's part of who they are as a parent. And to take that away from them really takes away some of their control as well. So if it's within the care paradigm wherever you're working, allowing them to do whatever they can. Corey.
I find it sometimes they overstep their bounds a lot of their boundaries. Even on my unit right now, today we have parents that dictates the care, but you have to inform them of everything you're about to do. If the dad don't know what medication was given, he'll go to trash and look at whatever he was giving, and so
Well, but
I would totally be that parent.
I was going to say, I've seen a lot of those parents. I've seen parents that have a notebook, and it's one thing to have a parent watching everything you do, and it's another thing to have a parent sitting there writing down everything you do. But basically, it's their child, and they want to be able, if something happened in 2 days, say, well, I know and it can be a very positive thing. I know they were given these meds when they were supposed to be given. So if we're seeing this, something else might be going on. But yeah, I mean, you need to tell the patient what med you're giving. Like, I don't ever give any patient a medication without telling them what it is. And quite frankly, I do that whether my patient is verbal, nonverbal, in a coma, whatever. Hi, Corey. I'm here to give you your meds. It's 10 o'clock, and like you typically do, I'm going to give you your Lipitor and your Nexium and whatever. And if you're unconscious, if there's your loved one at the bedside, they know what I'm doing. So I don't have to report to dad necessarily, but I'm never going to give a patient a medication without identifying what it was. And if that 5-year-old says, I don't take a blue pill, I'm going to say, okay, you know what? Let me go double check. And it may be that we use a generic and they've been taking a brand or vice versa, but somebody questions me, and that's all part of that, to me, safe medication giving. So it seems like sometimes it's an overbearing parent, but it's a parent who just really cares about their kid and wants to make sure that they know what they're getting. I think is kind of more the case. We have another comment here in Rochester.
I'm sure it's being completely loss of control, and having some control is they probably ask a lot of questions, and people that write them down. When my mom was in the hospital, I wrote down absolutely everything. I had no idea what I was writing, but it was the only control I had.
It's what you could do. Yeah.
So I'm sure if it was my child, I would be crazy.
Yeah. But what's the reaction to that?
Well, I noticed that a lot of the nurses has this okay, we're going into this room now, and we have to deal with taking care of the patient, because again, I work on physical rehab, so you have spinal cord and traumatic brain injuries, and they feel like when they go in there, dad is right over the shoulder, and where mom is more laid back. So yeah, I get it. Yeah, I'll be the same way with my kid too. But at the same time, there is a fine line where medical staff has to be medical staff and parents have to be parents. And sometimes I think but some particular parents, I think they go way beyond the medical staff to the point where now you're making this person feel uncomfortable because you're afraid that you're going to mess up because dad is scrutinizing everything that's done.
Yeah, and there are families that do that and there are families that don't. I would I would be more interested to kind of say to Dad, I see that you're writing up, you know, do you do something with that, or what? There may have been a prior experience. If this was a trauma, was Dad driving the car when the accident happened? And so, number one, guilt. So Dad's dealing with a lot of guilt, and I screwed up. I was driving the car, and now my kid's lying in a bed with a TBI. I mean, my personal philosophy in situations like that was to give as much leeway to those parents as possible, because that has to be a horrific situation for that individual, for the child, for the father, for the mother, for the family. I mean, when you talk about family, that's a prime example of how this one instance, and for me, it was so difficult as a nurse, because when you got report on that child that came through the emergency room, you knew that 4 hours ago, that family was in one place, and now they will never be the same.
Right, yeah.
That this event is horrific, and it's horrific for everyone in that family. But, you know, how much as nurses do we need to reach out to that dad who's dealing with all this guilt? And I may have shared, I had a kind of a similar situation where we had two teenage sisters were going out for a bike ride. The younger one had outgrown her helmet, so the older one gave the younger one her bike helmet. Didn't have a helmet for herself. They go out for a ride. I think she got out of the driveway, slipped on some gravel, and hit her head on the curb. Had a bleed. And we fought increased ICPs, intracranial pressures, for days. And literally she was on the edge, and who knew how much brain damage she would if she got out of this, and those kinds of things. And at one point, Dad shared with us that if she died, he was going to commit suicide, because she could not die alone, that he needed to go with her. And so, we were like, hello, we need adult psych up here. And initially we're told, we're pediatrics, we don't treat adults. And we were like, no, you don't understand. There's a outside patio on our third floor unit that he could just climb over and jump. Like, do you want his body in the driveway? Like, no, we've got to attend to this. And it was certainly before family-centered care was a thing. But, thankfully, the nurses that were caring for her and for the family had enough sense to say, this is not a good solution for this father, and we need to take care of him and make sure that, we don't have two tragedies instead of one. His plan was very long-term, so it was not an immediate threat, which was kind of how he presented first. He was going to get his pilot's license, rent a small plane, and drive it into the ocean, fly it into the ocean, and kill himself. But, it was just guilt, that family guilt. So I would say, I don't know what it's like to have a child who's been injured in an accident, much less an accident where I was the driver. So as much grace and understanding as you can give that family, that would be the challenge, because you don't know what they're going through. Fortunately, the young woman, the 13-year-old who I was talking about, actually had a really, really good recovery, made it to her 8th grade dance, and just had the slightest gait issue, but neurologically was totally intact, and was really had a really positive outcome. But anyway, we do think about the parents, because there can be guilt, denial, anger, depression, all of those stages of grief that Dr. Summerness went through last week. Right? You can have grief, right? So this family, they're grieving the loss of whatever physical abilities perhaps this child had, whatever dreams they had,
He will have, he's gonna be,
Yeah.
it's not gonna be right.
Right. So it's kind of like, he was, and I don't know how old he was, but he was on this trajectory, right? We saw that he had all these abilities and he had all, so, when a little baby's born, parents have all these hopes and dreams. Well, as that child begins to grow and develop and they kind of meet that child's personalities and where their strengths lie and things, that story kind of gets more and more solidified. And then you've got a traumatic event that happens and, the game changed. And just processing through that, that's another kind of grief that families realistically have to deal with and really need help dealing with. And that would be the thing is like, are they getting therapies and things like that as a family, as individuals, to help them deal with what the family and what they are going through. And so as the nurse, we provide family-centered care to all siblings, parents, and other family members. And in cases like that, it can be exhausting. I mean, it can be really very trying, but getting, recommendations for outside resources and following up with folks can be really important. Who are big highlighters? Anybody really just highlight? I was never a good highlighter because I would end up highlighting everything. And then it was like, well, that was nice. I just colored the page yellow. And I still don't know what's important. So to those of you that are able to pick out the important bits and highlight, better than I am.
I was just sharing that I used to fall asleep in my bed when I was highlighting, and so I had highlighter marks on my comforter in nursing school. So, yes.
Yeah, that's good highlight. It's a great philosophy.
It's a great philosophy.
I just was not good at discerning what was important in the reading. It's like, it's all important. I need to know it all, which is kind of the way I studied. I was a little bit of a maniac. Anyway, principles and procedures of care. Do we need a little quick break again, or are we good to plow through? Okay, we're going to push through. If anybody needs to take a little break, feel free. Principles and procedures. So preparation for procedures.
They are needing a break big time, so you're going to see people get up. I just wanted you to know. Okay.
That's fine.
All right.
Treatment room is the preferred location. We encourage parents or loved ones to provide comfort and support so they can be in the treatment room. And it's great if they are, because then once that procedure is over, once the IV is started, once the urinary catheter is in place, whatever it is that you're doing, once that's done, to that parent for comfort and support. And so that can really help solidify that child's kind of recovery from that event. Because now they're in those secure arms, they're where they want to be, and they know that their parent's not going to do anything to them. We're the bad guys. And use developmentally appropriate terminology. Again, we're not going to give a shot, and things like that. And then just do it. Right? You're going to want to have everything in the room. Again, we don't want to make this process any longer than it needs to be. So if you know you have to do X, Y, or Z, and you know you're going to need a Foley catheter, or you're going to need an IV with a bag of saline or a D5W, D5 half to hang, or whatever it is, have all that in the room, have it as ready and primed as possible, have extra Foley catheter kits if you're doing that, or whatever, because chances are you're going to miss the first one, contaminate something. If you need sterile gloves, have extra of those. Whatever it is you need, make sure you have it all so that when you bring the child into the room and you're ready to start the procedure, it's not like, oh, I forgot I need. Now it's just making it worse. Offer the child choices where there are choices. And so if you're putting on a bandage and maybe you've got a lot of different colors of wrap to cover it with, you can do that. And so, you get to pick the color. What color do you want today to wrap this or whatever? Tell the child and the family how they can help. So maybe there's something that the child can hold. Maybe, telling the parents if it's an injection, maybe you need the parents to hold the feet. Or maybe, and actually the foot of the bed is a good place if the parent can be there, because then they can look directly at the child and get that child's line of focus and distract, so that's the parent role. But giving them a job, giving them something to do, so that they're not just there being anxious themselves because their child's not, the child's uncomfortable. Don't threaten punishment for lack of cooperation. And if the parent doesn't want to stay, don't make them. Friends of mine had kind of a deal. If there was blood, David had to be in the room. If it wasn't bloody, Maggie could do it. But if the child was bleeding, she could not be present. She's like, nope, that's not my job. So, parents have different things that they're willing to be and be there for or not. If the parent can't get a control of their own anxiety, it might not be helpful for the parent to be at the bedside. It might be better for the parent to be outside, you to get another staff member, another nurse to help you with the procedure, and then go about getting the parent in for the comfort. And so here we see the parent with the child and the nurse starting an IV. Kids can cry. Kids can scream. That's not hurting your ability to insert an IV. That's not, if that's their coping mechanism for that procedure, it might hurt your ears. It's not comfortable, but that's okay. If this kid, a lot of times what I'll say to a child, if I'm not the one doing the intervention, hold and squeeze my hand as hard as you can. And then, as the procedure starts, is that as hard as you can squeeze? You can squeeze my hand harder than that. And so now they're not worrying about the arm that's getting insert the needle. They're working on hurting me. And so a lot of times that kind of a distraction will be enough to get them to cooperate. And, the more that hurts, the more you squeeze. Can you, wow, you're not squeezing very hard. Does that feel okay? Or do you need, so whatever it takes and however you can kind of distract them and be supportive is really what we're after. So which intervention should the nurse take when preparing a child for a procedure? Have a separate exam room for procedures. Insist the parent stay to reduce the child's anxiety. Use medical terminology when explaining. And reassure the child that the procedure will not hurt.
A.
We here think it's A. Concordance with the Twin Cities group?
Nobody thinks it's different than A.
Okay, good. Yay, because it is A. And so yeah, we would not want to insist that the parents stay, right? If they want to, they can. But if they don't want to, we would never make them stay. Using medical terminology, how's that going to work with a child? Right over their head. Right? They're not going to, you're going to be talking to them in a, think about even when you started nursing school and the first kind of medical terminology that was thrown at you, or some of the acronyms for everything. I mean, it was a foreign language to me when I started nursing school. I mean, we had vocabulary tests. basically had vocabulary tests, pronunciation, and like definitions, because it's a foreign language. And so a child's not going to understand it. And we want to make sure that if we are explaining things to them, we explain it to them in a language and in a way that they developmentally can understand. And procedures hurt. So we would never want to just, as a rule, tell them it's not going to hurt. We'll let you read this at your leisure. The mother's strategy for handling the hard stuff. But it is hard stuff. And it's not just hard stuff for mothers. Right? It's hard stuff for any parent. It's hard stuff for siblings. Has anybody had to watch their sibling go through a bad injury or medical treatments or anything like that? Anybody want to share what that was like? Or okay, we've got a couple here, and then if we have any in Twin Cities, let me know. Yeah.
We were injured at the same time, like probably a good 10 minutes apart. And so like we were getting ready to just go to the hospital because both of us needed those injuries to be assessed. And he actually fainted on me, I think from the shock of his injury.
Mm-hmm.
And it was just really hard on me, and I just, wanted to care for him, and it was
scary.
It was hard, yeah, because he's younger than me,
Mm-hmm.
so.
Okay, somebody else here had another, yeah.
So when I was little, my brother's 2 years older than me, and he always was just like getting super annoyed that I wanted to like come with him everywhere. And one day, like we were coming back from the park, and he's like, "Okay, fine, just get on my handlebars, like on the bike."
Mm-hmm.
And he was riding his bike, and then he wanted to be cool with some of his friends and let go of the handlebars. So then I fell and hit my head, and I was like unconscious for probably like over 24 hours, and
Oh, wow.
they thought I was gonna have like brain damage, like all of that. And no one asked my brother like how he was doing, and like even to this day, like he said that was like the scariest moment of his life, and
Mm-hmm.
no one like acknowledged him, and like my parents were like yelling at him. So yeah, it's just kind of seeing that, and, like for him, he said it was like really traumatizing.
Mm-hmm. Yeah, because it was his fault, right? And not only probably was it his fault, but he felt very responsible for that. And so that, I mean, when you think about a young child or a child, that's a heavy weight. That's a real heavy weight. Anybody in the Twin Cities?
Anyone? Nobody here.
Nope. Okay. So really, it's all hard stuff, and it's really developing, some coping, reaching out and getting help, recognizing when other members of the family might be struggling, and things like that, because it does affect everyone. Moving on to standard precautions, and this is probably a review. Yes, hopefully. About standard precautions. So they apply to our pediatric patients as well, right? We're not going to think, oh, they don't have any infections because they're young. We can't do that. We treat everybody the same. Everybody gets standard precautions. So to prevent infection, body and blood, body fluids, non-intact skin, mucous membranes. Think about how many times with especially our little ones, those mucous membranes putting out all sorts of stuff. So we really need to kind of be involved with that. We do need informed consent, and that typically is provided, that is provided by the child. No, it's not. That is provided by the parents. So we would need to know if there was any non-custodial parent arrangement that, one parent was not allowed to sign. An emancipated minor can sign for themselves. So there's a couple of situations where we would need to that are exceptions. But overall, informed consent, we need to go through the same kind of procedure that is done for adult patients, and it would just be that the parent is signing for their child. Often it's the healthcare provider, the nurse practitioner, the MD, the surgeon, the anesthesiologist or anesthetist that would present, the nurse midwife that would present this to the patient, and then the nurse witnesses that this consent was covered, questions were answered. And then for our children over the age of about 7 or 8, typically assent is desired. So we want them to know what's going on and that they understand and are okay that this procedure is going to happen. Questions? Document, document, document. So you want to document the preparation that's done, and the preparation for the child, for the family, what pre-op prep has been done, the key elements for the procedure as they go through it, who performed it, and when the child comes back to the unit, the assessment of that child and how they tolerated, the report, how did the child tolerate that procedure. So all that needs to be documented. If it's a surgery, if it's placement of an IV or a Foley catheter or something like that, when they come back from the procedure room, you would want to also document all those things. Safety, safety, safety. We do want to make sure our patients are always safety no matter what their age. Infants and toddlers are at the greatest risk for injury. We put them in cribs a lot of times, and we need to make sure side rails are up, and if there's a cover that comes down, and I understand now that's pretty controversial because some people say that's a restraint, and it's like, yeah, because otherwise they're going to fall out of the crib and they can climb out, and that's a risk for injury too. So it's kind of weighing that, but we do want to ensure that if a side rail is down for an infant or toddler, there's always an adult responsible there. Techniques such as distraction to be used during procedures instead of restraints are advisable, and when restraints are used, it's absolutely the last resort. Crib rails up at all times. I had a student who had a 6-week-old patient actually, little baby, and baby was on a cardiac monitor, so had IV lines and some electrical, the EKG lines, and got them caught on the crib handle while he was changing the sheets. And so he's, as I've done, you try and, undo it while you're doing this and hit the baby's head on the top rail of the crib. And so I was pretty amazed that he could do that, because I was like, I would have had to throw the child to do that. But he was taller. I'm very short, so he was much taller than I was. But he came and said, this is what happened. And I said, okay, well, I did an assessment. We wrote up an incident report. The nurse practitioner came and did an assessment. Mom had been right at the bedside. So Mom had said, the baby seems fine. I said, yeah, but we just have to do this. This is, our protocol. And, after the fact, the student looked at me and he said, am I going to fail clinical? And I said, absolutely not. And he looked at me kind of shocked and kind of relieved. I said, no, you were most concerned about this baby. Yes. I said, I guarantee you will never hit another baby's head on that rail. I said, oh, no, I would. I said, no. But I said, you took absolutely the appropriate actions. I said, now, you would have failed clinical if at the end of the day you left, I went into the room, and Mom told me you hit the baby's head and we had done nothing about it all day. That's a concern. But basically, you took all precautions to make sure this child was safe. And that's what we want to do. So sometimes it's kind of like raising the hand and say, I did this and it, wasn't safe here, but at least what I've done afterwards was totally ethical and totally with following our procedures. But crib rails up all the time. We do not want those little ones crawling out, falling out, rolling out. When you're changing, and as I said, when you're changing diapers or doing anything and the side rail's down, you have one hand at all time on that crib. So you really can't leave the crib unless the side rail's up. Restraints, and this is the same probably as you've seen anywhere else for restraints. It requires a provider's order. We use the least restrictive for the least amount of time. We ensure that the device is working properly and that it fits. We tie the knots so that they can be easily undone, and we secure it to the bed frame, not to anything that would raise or lower, so that it doesn't tighten as if we raise the head or the side of the bed. That's pretty standard, what you know. We frequently check distal perfusion, right? We want to make sure that they're not too tight. We want to observe in our real little ones that won't be able to tell us if something feels too tight. We want to really inspect that distal extremity to make sure we still have a good pulse. We've got good cap refill. It doesn't look like there's swelling or any kind of impeding of venous return that would cause that. We want to remove those every 1 to 2 hours. So, yeah, all pretty much the standard of what we look at there. We want to make sure our kids are clean and dry. So bathing infants and children, we can do sponge bath or a tub bath, depending on the condition and what's going on. For older children, there may be a shower available that could also be used if they're able to get up and out of bed. Oral hygiene is important from the youngest of our patients to the oldest. So we want to make sure that for our little ones, while we're doing care, we can take a washcloth and just go along the gum line, make sure they're not pocketing or have any pooling of any of the feeds or anything like that, and that our older children are brushing and flossing. And that's good to model for home as well. So this is important to us, and you should also be doing this at home. Feedings, foods must be appropriate for the infant or child's age. Breast milk or formula never warmed in the microwave. Hospitals have a policy and procedure if the parent brings in breast milk and needs it to be stored to be given to the child. Bottles should never be left propped up, and that's in the hospital. That's teaching for parents at home. We don't want to leave a bottle propped up. Milk or formula, breast milk also, are high in sugars. And if a child is left with a bottle just propped up, that milk will tend to pool, or formula will tend to pool in the mouth. And if they've got teeth, it starts to rot the baby teeth. And so we have seen in 2 or 3-year-olds total decay of all of the teeth because they've been left with bottles propped up, and it just over time totally causes cavities of all of their teeth. So never prop up a bottle. Some procedures that we may need to do: gather a urine specimen, blood, stool, sputum, throat, cerebrospinal fluid, bone marrow aspiration. Those are all procedures that may be done at the bedside. So for us, at the bedside would be in the procedure room, right? For adults, we would do these things in their bed. For kids, we want to take them to the procedure room. We don't want them associating their bed with the need to gag for throat culture and things like that. A stool, and depending on the urine culture and depending on the age of the child, if they can urinate in a urinal, we could get a basic urine culture that way. If they need to be straight cathed for a urine culture, I would take them to the procedure room. So some of that also just depends on how we're obtaining that specimen. Make sense? Kids do get NG tubes or G tubes, and we would want to verify placement of the tube before any feeding begins. If it's an NG tube and we see any signs of respiratory distress, cyanosis, abdominal distension, or vomiting, we would want to discontinue those feeds, notify the physician immediately. Kids that are getting tube feedings often lose the desire to suck, and so by providing them a pacifier, we can stimulate their oral reflexes while a feed's going on, and thereby hopefully maintaining that suck so that if they no longer need tube feedings and can begin feeding by mouth, they might more readily be able to do that transition. Kids that are say intubated and have a G tube or an NG tube early in life forget how to suck, swallow, feed, take in food, and chew. And it is amazing how intricate a process taking food in your mouth and chewing it and preparing the bolus and moving the bolus back to the rear of your mouth and then swallowing. If you ever get a chance to talk to a speech therapist about what it takes to swallow, it's mind-blowing. It is a science in and of itself, and that's why when we have people that are having difficulty with feeding, we do a speech and swallow eval, and the speech therapist comes and does that because they're so closely tied together, and some of these infants who don't feed early need intensive retraining to overcome oral aversions and to learn how to really eat. We can give oxygen therapy, nasal cannula. We wouldn't want a nasal cannula at more than 6 liters per minute, and that's probably for a kid really kind of on the uppermost, and for a baby you wouldn't want that much. You can have a face mask, you can have an oxygen hood or tent. The thing to remember about an oxygen hood or tent is that it actually covers the child from about their mid-abdomen over their head. And if you've ever seen one, it's plastic, it's clear, and it just sits so that it just envelops them. It's humidified oxygen in a plastic environment. So it traps that moisture. So one of the things in addition to that oxygen therapy you're going to want to remember is hygiene and keeping dry is going to be really, so you're going to be probably changing the linens, possibly changing clothing on that infant more frequently because things get damp from that oxygen hood or oxygen tent. We do assess O2 sats. And we can do that through pulse oximetry or through blood gases. And I think, yeah. So pulse oximetry, I think in A or B, that's typically what we see with adults, right? We see a hard or maybe a flexible rubber probe that goes on their finger. For children, it's a elastic wrap that goes around either their finger or you can put it on their toes. And a lot of times with little ones, their fingers and their hands are so busy doing things that is problematic for them. And so if we stick it on their toe and put a sock on, they'll leave it alone and we'll get better readings, get more consistent readings, keep that pulse oximeter on. So in C, we can see how that pulse oximeter is around that infant's toe. For surgical procedures, we want to make sure that all the preparation for surgery is completed before we send them down to the OR, to include probably hanging an IV of antibiotics. A lot of times that's on call to the OR. And then anesthesia will do the induction, post-anesthesia care, and as I said, a lot of times kids come out and are just wild. And then post-op care. So what kind of surgery was done, what kind of wound care is needed, When can they be up out of bed? When can they eat? When can they begin eating? Are there any restrictions to their diet? If an individual has had a tonsillectomy and they're not quite as in vogue now as they were when I was a kid, but we wanted to give nothing red by mouth post-surgery, because if they did start to have some fluid coming out of their mouth, maybe vomiting or whatever, if it was red, we didn't want to have to guess whether it was blood or cherry juice or cherry jello or red jello or whatever. So just what kind of orders are there and what do we need to consider in that post-op care. And then the last item I'd like to consider is med administration. And we can touch on this a little bit more, but really, this is another area where kids are not miniature adults. Right? Metabolism is different, their intestines work differently, their liver works differently, their kidneys work differently, not as mature. So they have different disposition of fat deposits. Their percent water is different from adults, so they have more water in theirs. So there's a lot of things that really, and their size is different. And quite frankly, why someone that weighs 108 pounds, an adult that weighs 108 pounds, should receive the same dose of something as an adult that weighs 250 pounds, I'm not sure if that's good science. But that's what we do for adults, right? Typically, it's Tylenol, take 2 pills. Motrin, take 2. You shouldn't take more than this many in a 24-hour period, but we all pretty much take the same dose. For kids, it's not that way, right? Kids is mostly based on weight. Did you have a question like that on ATI yesterday? Was there a kid med question? No, okay. So we really need to consider the pharmacogenetics and look at all of these different things, the absorption. So how are we giving it, right? Something we give IV is absorbed differently than something that's taken by mouth. So we need to consider, how is it being absorbed? Where is it being distributed? And how is that different? What's the metabolism, the excretion, and the concentration? So here we look at our little guy, and we see all of the immaturities of systems that really contribute to their having different pharmacogenetics. We see that they've got rapidly growing tissues, right? We don't grow nearly as quickly at our age as that baby between the time they're born and the time they're a year old, right? Between the time they're born and the time they're a year old, what do they do with their weight? Anybody remember? Triple. Double by 6 months, triple by a year is the basic standard. So that's a lot of growth in a year. We don't grow that much. I mean, if we doubled our weight in 6 months, that would not be a good thing. So, they've got rapidly growing tissues that need to be supported. Large body surface area. So immature renal function, immature different absorption patterns, delayed gastric emptying relative to gastric acids. They've got a lot of gastric acid, but things sit in the abdomen, in the stomach a lot longer. So an immature hepatic system, immature hepatic metabolism, so the liver works a little bit differently. High total body water and low body fat. So something that is absorbed in the fat is going to be different than adults, and something that relies on water distribution is going to also be different. They have a higher metabolic rate, so it's just going to pump through faster, so they will process it faster. Differences in protein binding, so if you've got things that bind to proteins, it's going to be different. They have an immature blood-brain barrier, so where things might not cross our blood-brain barrier, it may cross theirs. And increased permeability of skin and conjunctiva. So if we have a patch of some sort, it's going to be absorbed more readily than it would in you or I. So a lot of differences in the body of this infant that makes really giving medications a whole new science. And fortunately, we've had studies and pharmacologists who look at that and who have come up with and really are our experts. So if you're ever working in pediatrics in a pediatric hospital and you've got a question about a medication, call your peds pharmacist because they are fabulous and a great resource. Standardized dosage ranges in most things haven't been established, so they're weight-based. Kids respond differently. Like we said, coming out of anesthesia is one example. We can think of probably a host of medications. The ones that come up to mind most readily for me are some of our psych meds. Don't give under the age of 16. Don't give because those systems react differently than they do in an 18-year-old or a 28-year-old or a 68-year-old. We also have some of those precautions, though, when you think about it, at the higher end of the age range, too, right? We know some of our geriatric patients respond differently to some medications than they do in a 40-year-old, say. So both ends of the spectrum sometimes have some really strong parallels, but for our kids, some medications, they just react differently. So we need to incorporate our knowledge of growth and development when we administer meds, because also sometimes they just don't want to take them. And a lot of times we have a very narrow margin of error. So we really need to pay attention. We need to know how to calculate, is this dose safe? We never depend on the doctor or the nurse practitioner or the PA to have done it correctly. We will always double check and order because there's a narrow margin of safety and we don't want to overdose. We don't want to overdose anybody, but an immature liver, immature kidneys can be, and a high rate of metabolism, or high metabolic rate, can do a lot of damage very quickly. So strategies for medicating children. With infants, we can cuddle, we can comfort. A lot of times for oral medications, they will be liquid. And if it's not a large amount, we can actually just put it in a syringe, have it measured that way, and slip it inside the side of their mouth, and they swallow it. I can tell you, though, that you do that a couple times, and if it's medicine that tastes really, really bad, they get really good at thrashing their heads around so that you cannot you will spray them and yourselves with medication. So it can be a challenge, and it can be a challenge regardless of the age. But cuddling, comforting, having the parent secure the child, and you giving the med can be one way to do it. And then when you consider that as nurses we have this challenge, but if we send a child, an infant, a baby, home on those medications, those parents have to do that, and they have to do it 3 or 4 times a day perhaps. So trying to come up with ways to make it work can be helpful for us, and also in giving hints to parents. But if a parent looks at you and says, yeah, good luck, I've tried everything, you could be in for quite the challenge. For toddlers, using play, minimize restraint, give praise, stickers afterwards. So giving some sort of a reward when they've done it. If it's a decent tasting medicine, they may just take it in a medicine cup and swallow it. And that's kind of just working through what's going to work. Some kids like to use the syringe and squirt it in their mouth. That's fine too. So long as it gets in and they swallow it, we're happy, they're happy. Offer the preschooler choices. School-age children, again, provide choices, explanations, distraction, and support. And we would expect that as the school-age child comes along, they are more participating in their care and hopefully more cooperative. And adolescents, explain, allow participation in decisions. Maybe there's a choice between having a tablet or having a liquid. And maybe they can make that choice. Maybe they would prefer a pill, or maybe they don't want a pill. And so, if there are decisions to be made, they can be participating in those, and praise their cooperation and provide an outlet for frustrations, and allow them to express their frustration. Being in the hospital is not all the time joy, happy, let's go party. And just to acknowledge that sometimes is helpful. Yeah, I wish you didn't have to be here too. This does kind of suck, but we're going to try and make the best of it. What could make this a better experience? And maybe they have something in mind. Maybe there's nothing, but at least you've asked and tried to intervene. Calculating doses, we add safeguards whenever necessary. Medication recommendations by dosage are usually milligrams per kilogram per dose, as well as milligrams per kilogram per day. So a lot of times what you'll see is, for this medication, it's recommended that the child get 2 milligrams per kilogram per day in 4 equal doses. So for something like that, you would need to know their weight in kilograms, figure out what the daily safe dosage is, and then what would a single dose be. And a lot of times for peds, it's a range. And that range is the safe dose. So it might be between 15 and 20 milligrams per kilogram per day is the safe dose. So you would have to calculate both what would 15 be, so what's my low per day, what's my high per day, and then you've got an order that tells you what to give it at one time, which you would have to multiply then, if it's 4 times a day, by 4 to see how many milligrams that physician or that healthcare provider has ordered, and is that within the safe range. Did I lose everybody? We'll go through some, and we will practice some. We're not going to have time to do the med sheet, but there is a med calculation sheet on the page. Look at it, go through it, and then we'll review it at the start of next week. There will be probably 1 or 2 med calculation questions on the test. You are not going to like me because I'm not going to allow you to use computers. So if you forget
Calculators,
how to
you mean?
Well, calculators, computers, any form of digital technology that would help you with your division and things like that. I know everywhere you are, as far as NCLEX, as far as ATI, there's a pop-up calculator. But you might be in the back of a rig and your phone dies and you don't have electricity. Or you might be a global nurse and you're somewhere in a community that only has electricity 3 hours a day or doesn't have internet when you need it. And you may be taking care of kids and need to figure out. So I'm willing to, the next time I'm down here, I think would be before the next test. If it's not, I'll arrange something that we can do online video kind of conferencing to review the division. I can look at that next week a little bit, but it will be 1 or 2 problems that you will not use calculators for. No, I know. It's one of my few non-negotiable kind of things. I think I'm pretty flexible on a lot of things, but I just truly believe that we need to have some sort of a feel for the math behind it and be able to manipulate some numbers. So, and I'm willing to help anybody that says, I don't remember long division with decimals. Come see me.
You want a test?
No. Before the test.
Right. And this is not something that should be too difficult. So it's just division, making sure you know how to do that.
Yeah, it really is I say just because I love numbers, but I understand that some people
But
don't.
division is not like algebra equations.
It's long
okay?
it's long division used with decimals because you're going to be given a weight and you have to divide it by 2.2. That is a given.
That's right.
The weight will be in pounds. You'll need to remember that you need to convert it to kilograms, and you'll need to be able to convert it to kilograms. So that's probably the most complicated of the math, but yeah, we'll go through some problems next week. And again, I like numbers, so I'm willing to work with anybody till you get it. The 6 rights, or 12, or 14, or 21, I know you hear different things from different people, but we always want to make sure it is the right patient, it's the right drug, it's the right dose, at the right time, the right route, and we've documented it. And if that child says, that's not what I take, go and double check. Because a 6-year-old could be right, and I could have picked up the wrong nebulizer. I could have been dispensed the wrong, somebody could have messed up somewhere along the way. And so I am going to double check and make sure that that is the right med at the right time. We administer based on the child's developmental age, and sometimes that's also route dependent. If a child's got strep or something, they may get a shot of penicillin instead of sending them home with 2 weeks worth, just for ease of delivery and treatment. Or if parents, there's a lot that goes into it, but there may be reasons for an injection, one-time injection versus an oral medication. And then some of the different alternative routes. And we do, explain it. And like I said, I do explain it to the infant because I know the parent's listening, because the parent's in the room. And so, I will come into that and it's like, oh, it's time for your whatever I might be giving, or it's time for me to hang your antibiotic again. Remember, this is your penicillin, and I'm going to run it over 30 minutes, and then your IV will start up again. I'm talking to the infant, but I know whether or not that parent is writing it down, that parent is listening to every word I say. And so it's one way that I can do that in a conversational way rather than a report way, and I'm also talking to that infant in a very calm and soothing voice, and it's that sing-songy, so they're looking at me. The other thing, any of you that wear glasses, babies love glasses because they see their own reflection, and they just are mesmerized. Use that. Makes you the baby whisperer. It's great. We can look at that next week. So kids get IVs. I will continue with this next week because it's noon and you guys have been in for the long haul, and I appreciate that. Any questions before we depart for the day? Twin Cities?
We're good.
Okay. Have a great afternoon. See you next week. But I want to come back around on meds.
Based on situation, can I convince you about the situation where I will at least have a calculator?
Nope.
I will make a calculator out of copies.
Nice to go home.
Jane, this Monday, did you see my thing at 11 work?
Yeah, that works for me. Thank you.
Yeah. I know you had a long shift and stuff.